You took the time to fill my needs, educate my mind. You hold me when I was down, console me, turn my life around. You led me to a higher place where I can feel your warm embrace. Now that I've seen what you have done, I understand you're the only one. Yeah, 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 yeah. What a glorious feeling. And thank you, Jesus. So, so glorious feeling. Lord, I wanna thank you. Thank you, Father. What a glorious feeling. Lord Jesus. Yeah, yeah. So special. So wonderful. So special. So special. Part of my life. So special. Nobody but you, yeah. You wanna say, yeah. You wanna say, yeah, 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 yeah. Lord, so special, and I want the world to know. Thank you, Jesus. Thank you, Father. Thank you, Jesus. Thank you, Lord. Wanna thank you. Wanna thank you, Jesus, for saving me, making me whole, healing my body. And I wanna thank you, Lord. I'm so glad. What a glorious feeling. I wanna tell the world about it. I love you, Lord. What a glorious feeling. Feels so good in my bones. Hey, 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 hey. What a glorious feeling. So very, so very, so very, so very special. What a glorious feeling. Father, I thank you so much. So special, so special, a special part of my life. So special, so special, so special, a special part of my life. Only you know what God can do. When you're laying down in that hospital room, don't think you have nowhere to turn. Steps right in. Yes, he does. Heals your body. Heals your body. You call on what you say. Father, I wanna thank you for blessing me, yeah. When all hope was gone. Oh, yeah. You made me see the light. Hallelujah.
Okay, so we're gonna get started in 5 minutes. If you have anything that you need to get done, if you have anything to do, you have to grab something that you can start, you can do that. But we're gonna start on time, so 5 minutes. Alright, thank you.
gotta wake up. You gotta wake up. Say hallelujah. 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 Hallelujah.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotics site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
This morning. My name is Jan Walcott Watkins.
And my name, if you don't know, now you know, is Nakia Rowe, and we are your moderators for today. As you can see, we are on schedule and we are gonna have an exciting meeting, yes. Right? I'm looking forward to it. So what we're gonna do, we're gonna have an invocation just to start off our program, and then afterwards we'll invite our AGPJ rep, but also we'll have some host rules that Gian will lay out for us today.
Right, so just a few host rules before we start. Please put all devices on silent for the rest of the event. Question and answer sessions will be at the end of each presentation. In order to keep a tight schedule, lunch will be served, it will be plated, and it will be served while you're seated. There's also a coffee break. Coffee is to my right, your left. And if you observe the agenda, you'll see that the coffee break is at 10 o'clock. Restrooms are around the corner. Upon exiting, they're to your right. All right? Be inquisitive and attentive, and please enjoy.
Definitely. So are we ready? All right. So we definitely have a really studious audience here. But before we get everything rolling, we're going to have a prayer, as I mentioned.
All right. Can we bow our heads as we pray? Almighty and everlasting God, we humbly come before your throne of grace as we gather for this event. We acknowledge your sovereignty and power, and we invite your Holy Spirit to fill this place. transforming it into a sanctuary of your presence. Lord, as we embark on this journey together, we ask for your divine guidance and protection. May your wisdom and discernment be with us, the organizers, speakers, participants, ensuring that each decision made and every action taken is aligned with your will and purpose. We pray that this event will be a powerful instrument for your glory, and that all who attend will be uplifted and inspired. Open our hearts and minds to receive the messages and lessons you have prepared for us. Father, we ask you create an atmosphere of unity, fellowship, and love among everyone present. Help us to forge strong connections and build lasting relationships, all for the furtherance of your kingdom. Grant us the strength, courage, and resilience to overcome any challenges and obstacles that may come up. As we begin this event, we dedicate every aspect to your name, your glory, your honor. May this gathering be a testament to your love and faithfulness. In Jesus' mighty name, we pray. Amen.
AGPJ, please make him feel welcome. Thank you.
Thank you very much, Nakia. Gio, and I can see I didn't miss anything by not going to church this morning. Your invocation was excellent. Okay, I'm sure we'll get a lot of blessings from it. Good morning, and special greetings to our esteemed presenters, Dr. Curtis Wright, Dr. Pete Robinson, Dr. Marsha James, and Professor Alverston Bailey. To special greetings to SANDOZ overseeing team members, Alicia and Tatiana, to our colleagues present in the audience, and to those online, and to those present throughout the region. To our local SANDOZ team members, moderators, chairpersons, Naki and Gian, Oldgate technical team who always satisfy our technical needs without any itches. I am Dr. Gordon, President of the Association of General Practitioners of Jamaica. It is my honor and pleasure to bring greetings on behalf of the association and its membership to you, our valued guest, as we join SANDOZ in hosting its 4th Antibiotic Health Summit. The infectious topics in this health summit, though not exhaustive, was chosen to highlight the correct prescribing and the current use of antibiotics in particular clinical situations. As we all know, the overprescribing and the indiscriminate use of antibiotics without reference to its proper clinical context is one of the main causes of antibiotics resistance. The organizers and speakers sincerely hope that at the conclusion of this antibiotic summit, we as practitioners will all exercise more knowledge and diligence and discretion in our choice of antibiotics. It has always been our pleasure as an association to work with the SANDOZ team, and we welcome the opportunity to continue this relationship under the leadership of the SANDOZ team and its members. As an association, we are delighted. Sorry. As an association, we are always delighted to partner with the SANDOZ brand. We are sure the relationship will continue to be fruitful, effective, and progressive as it has been in the past. SANDOZ and the association has had a long and unbroken relationship that goes back quite a number of years. We are certainly looking forward to a continuation of this relationship in the future. It is a relationship that is built on trust, mutual respect, and it has been mutually beneficial to both parties. SANDOZ has always been kind and supportive of the association in the pursuit of its CME activities. And for that, we are very grateful. The hosting of webinars and hybrid meeting like this, along with the detailing of the pharmaceutical by your highly trained medical representative, goes a far way in educating our members in the various clinical topics which impact our daily practice as family physicians. We are eagerly looking forward to the contents of today's meeting, as it promises to be a very interesting one based on the roster of distinguished speakers. In closing, we wish for a continuation of the mutually beneficial relationship between SANDOZ and the association. And we are very confident that today's meeting will be a very successful one. Thank you very much.
Thank you so much, Dr. Gordon. And we want to say it's mutually exclusive that we continue this relationship in a very wholesome manner that we have done so far. At this point, we'd like to introduce our team members. So I'll ask Gian to do so, please.
Right. So to start off, we have some very important principals who are here with us. So we have our brand manager for antibiotics, Tatiana.
We've had to let everybody see you all the way from Costa Rica.
All the way from Costa Rica, Tatiana.
Yes, 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 yes. Make her feel welcome. Warm Jamaican welcome. Thank you. Thank you so much. Thank you, Tati.
And we also have our beautiful commercial manager for the West Indies. She's hailing from Trinidad, Alicia. Please make her feel welcome. And then we also have our first line manager. Please give it up for Mr. Christopher Beecher.
Woo!
Let me see, where are they? I'm searching for POS managers, right? POS coordinators. Okay, so we have Mrs. Leslie Woolry-Ferrell and Miss Trudy Ann Walters over here. And of course, you have our antibiotics team. So I'm a part of the antibiotics team. I have to introduce my people first, okay? Jan Walcott-Watkins from Antibiotics, hey. You see, antibiotics brings all the energy, you know. Over here, you have Sashane Francis. And we also have Wayne. I'm sorry, that's an inside joke. For our cardio team, we have Nakiro.
We'll bring the energy more.
Yes. All right. And we also have, I'm looking, where can I see Christian Freighter? And then hailing from the North Coast, we have Miss Sana Pitkin-Cover. Our newest representative, Ashley. All right, and from the institutional team, you would know Mr. Javan Cameron. Is Ibo here? Oh, is Ibo here? And we also have Ibo Sinigo. Is he here? Oh, he's not here. But thank you so much.
Okay, give a warm welcome and a round of applause to our SANDOZ team. As you know, we are very committed out there in the field. You see us every month. I know you're happy to see us, but we are out there tiring and working hard for the company as well as for your patients, and to make sure we provide affordable and quality medication. So you can definitely look forward to us continuing with that hard work. So we are here now, and so we're going to get right into the meat of the matter. And again, I like to say good morning for those in attendance, but we also want to say good morning to those that have joined us virtually. And so far, we have over 580 persons joining us online. Yes. Maybe they're still in bed, so, but we do understand for those of us who have dragged ourselves out of bed, you know. But of course, it's a large community. There are persons in other territories that could not be able to make it to this venue this morning. So far, we have over 1,600 that have registered. So we are looking for this number to continue to increase throughout the meeting. And of course, we really thank AGPJ for always facilitating the SANDOZ team. It's always a pleasure working with you. But we also have Sam and his crew around the back there who will be doing all the audio visuals, and they are always on top of things, as we say. We also have our SANDOZ team members that were just introduced, who are always doing the hard work. Thank you, guys. Now, this, as mentioned, is our fourth installation of the SANDOZ Summit, and the title for today, as you are already aware of, is SANDOZ Antibiotics Health Summit. And I must say, the lineup is pretty powerful. Shane Francis to come and do the introduction of our first guest speaker. Please make her feel welcome. Thank you.
Good morning, everyone. My name is Sasheen Francis, medical representative for SANDOZ, and it is with utmost pleasure that I have the opportunity to introduce our first guest speaker for this morning. Consultant and head pediatrician at the Maypen Hospital, associate lecturer at the University Hospital of the West Indies, lecturer at the Windsor School of Medicine, Caribbean School of Medical Sciences, and the All-American School of Medical Sciences are just a few of the titles he holds. Dr. Curtis Price describes himself as a consultant pediatrician who is trained to manage the general needs of children and teens in the primary and secondary care setting. He sees a broad view of pediatric issues in the community he works, where he is able to utilize a balanced approach to treatment strategies. When asked the question, "What made you fall in love with your job?" his response was, and I quote, "I love pediatrics dearly. Children are happy, hopeful, malleable, giving, and grateful. It is the area of medicine where you are able to make the biggest impact prior to the onset of chronic, permanent, physical, and psycho-emotional issues of adulthood. Children say thanks sincerely. They say what they say from the heart," end quote. Dr. Price has presented at various conferences locally and abroad on pediatric asthma, autism, and rheumatic fever. He has published articles in the West Indies Medical Journal about the side effects of antiretrovirals in Jamaican children. Here to speak on the use of oral cephalosporins in ambulatory pediatric medicine, please help me welcome Dr. Curtis Price.
Good morning, everyone. All protocols observed. I would like to thank Christian and the SANDOZ group for inviting me to speak on this very, very important issue. I'm sure that you will all agree with me. All right, so the topic that I'll be presenting on today is the use of cephalosporin in ambulatory pediatric care. I hope I can. All right, can somebody help me with this? Fine, anywhere. All right, so children frequently receive antibiotic therapy that they do not need. As a result, children receive more than 10 million unnecessary antibiotics in the United States, and this translates to what happens in Jamaica as well. More than 60% of these prescriptions are in the outpatient department. And this means that a breeding ground is being created or has done already for antibiotic resistance. And actually, anecdotally and otherwise, we are seeing this happening before our eyes. I work in ambulatory medicine and also on the wards. And we're actually see this happening right before us. I mean, previously we would have treated patients with, many of the antibiotics we see here displayed. And we'll be using the same antibiotics, and these children are just so unresponsive. It is therefore critically important, especially in the ambulatory setting, that we approach antimicrobial management of common pediatric conditions with much more alacrity and with scientific prowess. Cephalosporins are antimicrobials that are grouped into 5 generations. When I was in school, I think it was 3, right? I'm kind of giving away my age. And it's based on its coverage for gram-positive and gram-negative organisms, and also based on the time when these cephalosporins were discovered. They are beta-lactam antibiotics, and many of you might be scratching your head going back, in your medical school days in pharmacology. What the heck is that? Like penicillin, they have what is called the beta-lactam ring. That sounds familiar to most of us? Yes. All right, I'm going to show you something that we borrowed from this technical web. That is really what the beta-lactam ring is. You see, it's sitting in the center of these molecules. So the penicillin is like the prototype. And as you go over, you see the cephalosporin, monobactam, and carbapenem. The side groups are what varies, and this will become important as we go on in the discussion, especially when we look at cross-reactivity and a patient who is sensitive or allergic to penicillin, and there's a discussion whether or not you can use cephalosporin, a very critical discussion. All right, so cephalosporins are the largest group of beta-lactam antibiotics, and they cover a broad spectrum of organisms. They are well tolerated, they are easy to use, and they are therefore a very good option for ambulatory, and of course, well available. All right, so there are 5 generations of cephalosporin, as we spoke before, based on their temporal discovery and based on their coverage. Many of you might remember when we discussed cephalosporins, we talk about a first generation, which tends to cover your gram-positives. And as we move towards, the latter ones, your second and third generation, second generation tend to cover, some gram-positive with gram-negatives. And as we move to third and fourth, they tend to cover more gram-negative organisms. All right, so that's basically what this slide is showing. Your first generation cephalosporin, an example is cephalosporin, and it covers a lot of your gram-positive organisms. So you'll tend not to use, like a first generation to cover a UTI, which we know, the organism predominating in that sort of infection will be your gram-negative organisms. As you move to your second generation, you have an expanded coverage, expanded activity against, more gram-negative organisms. So it's similar to augmentin, sort of, in its spectrum. And of course, an example of a second generation would be like your cefuroxime. All right, so we're going to quickly look at at some of the common infections that we deal with in ambulatory pediatric care. I'm going to overlap with some of the other presenters, but I'm going to do it in a quick superficial way. They're going to do it in more detail, just to emphasize the importance of cephalosporin in managing a lot of these conditions. So an acute otitis media is an infection of the middle ear, and it's the second most common diagnosis in the emergency room, second to an upper respiratory tract infection. And I'm sure many of you in your ambulatory practice would have seen a lot of otitis media. A lot of children have 2 to 3 otitis media for their lifetime. 80% of all children will experience a case of otitis media in their entire lifetime. Inappropriately managed acute otitis media can lead to hearing loss, can lead to meningitis, mastoiditis, cavernous sinus thrombosis, some serious complications to what initially might be a simple infection to manage. Over treatment though of an otitis media can lead to serious antibiotic resistance, right? And there has been an updated protocol from the American Academy and other international institutions read the management of acute otitis media. All right, I hope that all right, so the current AAP guidelines recommend watchful waiting with what is referred to as a safety net antibiotic prescription in certain patients. This is called the SNAP, approach. So this is because most of our children with their otitis media, it's really viral mediated. And therefore, most of them will settle with watchful waiting. However, if the child is immunocompromised or relatively immunocompromised, then antibiotic therapy is recommended. Other indications for treating, with antibiotics include all children less than 6 months. And of course, that goes without saying. Your child is less than 6 months, they are relatively immunocompromised, right? So they are at high risk for various complications associated with an otitis media. We mentioned our immunocompromised child, your ill-looking child. Children with craniofacial abnormalities, those are also at higher risk of complications related to an otitis media. And all these children must receive immediate antibiotic coverage. All right, there must be an art to pressing this thing. All right, so you say all children with an otitis media, they can be offered antibiotic therapy to treat an otitis media. However, some children can be offered the option of observation, that is the SNAP treatment, based on their age and severity of their symptoms. SNAP can be offered to a child who is between 6 months and 2 years with only 1 ear infected. So the approach that is currently recommended is that if you have a child who is less than 6 months and they have an otitis media, full stop, you treat those children. If they're 6 months to 2 years and they have a unilateral infection and they are relatively well, you can actually observe those patients with careful follow-up. If the child is over 2 years and they have bilateral ear infection and they are well, you can also observe those children with careful follow-up. All right, so it's not a one brush, covers all. You monitor your patient and you look at their social setting. You look at, what is happening. I work in Clarendon, and if I look at a parent and she tells me she lives way up in the hills and she won't be able to, come back for a timely review, then of course you're going to use sense and, and treat that child. First line therapies, of course, amoxicillin, and we currently use high dose, which is 90 milligrams per kilogram per dose in divided doses. This is indicated if a child shows no evidence of non-typeable H flu, namely an otitis media and an eye discharge. And of course, we have to be careful with our eye discharge, right? Because we know that viral infections such as your adenovirus can cause, conjunctival pharyngeal conjunctival fever, and they have an eye discharge, they have a sore throat, and they may have an otitis media. But we know that, non-typeable H flu, and of course, I'm talking about non-typeable because, again, in the old days, well, in the former days, right, I used to see children on the ward when we were at Bustamante paralyzed by H influenza type B, right? And of course, vaccination has really eradicated that. And now we're seeing emerging non-typeable H flu. So if you have a child, he presents with an otitis media, they have an eye discharge, you are obligated to treat that child because non-typeable H influenza is a serious infection, all right? And it will seed to the brain and bone and, cause very compromise the children in a marked way. So if the risk of H influenza is present, then use high-dose amoxiclav, right? Because we have a high incidence of resistance to amoxil when we deal with H influenza. Cephalosporin of the second generation is indicated for non-IgE-mediated penicillin allergies or for patients with poor compliance or poor tolerability of your amoxil, or you have penicillin-based organisms, penicillin-based drugs. All right, so this brings us to UTI. A urinary tract infection is an infection of any part of the urinary system, that is from the kidney all the way down. It's one of the most common bacterial infections in childhood. The upper tract refers to a pyelonephritis, and of course, by definition, a pyelonephritis in a child who's less than 2 is a UTI with fever, what we call a febrile UTI. All right, so that's the definition of a pyelonephritis in a child who's less than 2, and that's because the reliability of your renal angle tenderness, the thing that they taught us in school to do, is not very reliable in a child who's less than 2. Of course, the child who's over 2, renal angle tenderness is indicated and reliable. UTI overall is more common in girls. However, the prevalence is higher in boys less than 1 year, and even more so for children or babies less than a month, right? And this is because of the higher incidence of urinary tract abnormalities in boys at that age. After 1 year, the risk is higher for girls. So UTIs to a bimodal distribution. Prompt antibiotic therapy, did I miss a slide? Is indicated for symptomatic, sorry. All right. So UTI shows a bimodal distribution. The first peak is in the first year of life, and the next peak is 2 to 4 years. And that occurs during the potty training period. So we have a lot of children that go to school and the bathroom is nasty, right? I mean, I've visited the bathroom at school and the bathroom is pretty clean, but there's no bathroom, that is appropriate for these children. So they go to school, they hold the urine, they become constipated, they hold up everything, and it puts them at risk for, for UTI in those early stages. The most common causative organism, of course, is from the intestinal flora, and that is E. coli, which accounts for 80 to 90% of these organisms. Of course, your other organisms, which will include your Enterobacter, Klebsiella pneumonia, Proteus, and of course, all of those gram-negative type organisms will predominate your urinary tract infection. All right, I hope I didn't slip a slide, but prompt antibiotic therapy is indicated for symptomatic UTI based on clinical findings and positive urinalysis while waiting for your urine culture. This is done to eradicate the infection and to improve your clinical outcome. I remember as a young doctor, I met a little boy. I remember him clearly, a little Indian boy. He had a UTI that was poorly managed, and he developed a pyelonephritis. And I went to the postmortem, and when they cut that kidney open, there was pus. I mean, green, aggressive pus. He died from multi-organ failure from a poorly managed UTI. So we really need to eradicate the infection and to improve the outcome. The ideal antibiotic should be easy to administer. It should achieve a high concentration in the urine. It should have minimal or no effect on fecal or vaginal flora. And it should have a low incidence of bacterial resistance and have minimal or no toxicity. And of course, a low cost. The bacterial flora is very important because, as we are all aware by this, we have another system. Do you know that the number of organisms residing in our gut is more than the number of cells in our bodies, right? You know, so it controls a lot of stuff that, you know, intrinsic bacterial flora that resides in our bodies. So the least broad spectrum antibiotic should be used. Empirical antimicrobials that are indicated for use include your cephalosporins, and you know they can be used as first line for use UTI management. And of course, the one that we are most familiar with and most available would be your cefuroxime, and of course, cefprozil. The choice of antibiotics should take into consideration local data and personal data of antibiotic resistance pattern. All right, so you need to be aware of that while you treat. So these are empirical therapy, meaning you take, and please, for children, I don't know how we manage adults these days, but for children, you need to take off a urine culture and advise them to do it properly, right? So the foreskin can be retracted. You retract the foreskin, you do some cleaning, they urinate, they catch the second part of the urine, and you do that prior to starting antibiotics on all children, all right? We also repeat for our local recommendations, you repeat the urine in 48 hours after starting and also 48 hours after completing the antibiotic therapy. Remember that little Indian boy that I spoke to you about, all right? The antibiotic may need adjusting based on the response to treatment. So it's empirical antibiotic therapy. So we start our therapy. When we get back our results, you know, within 48 to 72 hours, you can adjust the antibiotic coverage accordingly. All right, so we quickly look at community-acquired pneumonia. It's a lower respiratory tract infection occurring in a child who has not resided in hospital or a health care setting in the preceding 14 days. While the etiology of pneumonia is not often easy to ascertain in the clinical setting, the greatest clue is the age of the child, right? And this is very important. Overall, we know that viruses predominates, right? They are the most common organisms for pneumonia in the first 2 years of life, and they account for 90%. So most of the cases of pneumonia in children who are less than 2 years old are going to be viral in origin, and hence, you know, do not need antibiotic treatment. The most commonly implicated viruses are your respiratory syncytial virus, your parainfluenza, type 1 to 3, influenza A and B, adenovirus, rhinovirus, and less commonly, you know, your enteroviruses and HSV. With increasing age, though, the incidence of pneumonia decreases, but the bacterial pathogens, including strep pneumonia, mycoplasma pneumonia, and chlamydia pneumonia, are more common. So even though, you know, we have less pneumonia, if you have a bacterial pneumonia, then these are the organisms that you have to consider in your older child. In children aged 15 years of age, strep pneumonia accounts for 17% and 28% of all community-acquired pneumonia cases. And just to say quickly for your bacterial pneumonia, as I said, for the younger children, you know, it's really supportive care. You have a child who is having a little runny nose, she's coughing, you know, she looks relatively well. That child can be supported, you know, and observed. A lot of them might wheeze because small children, when they have respiratory tract infection, they tend to wheeze. Initial antimicrobial therapy is not routinely indicated, I said that before, for our young children. Amoxicillin is the first choice for oral empiric antibiotic therapy for the school-age child. And of course, we are covering strep pneumonia, and we are considering that these children have gotten immunization against Haemophilus influenza, right? So in that case, your amoxicillin would be appropriate. There are a lot of individuals who are concerned. So I have, and some of you might do that in your practice, where you cover, you know, with dual therapy. So you might use a cephalosporin, or you might use augmentin, and then you use a macrolide, right, in combination. Some people take that approach, and actually there's some you know, infectious disease international bodies that recommend that, right? But what we generally recommend that you individualize the approach. I mean, you know, go back, we in the you know, we're trained in this setting. We know that we have to approach our things, you know, by taking an appropriate history, doing your physical examination, an appropriate investigation, and then you make your decision based on that. All right, so another thing that we see in ambulatory pediatrics is impetigo. Impetigo is, are you seeing impetigo a lot in your offices? Yeah, seeing quite a bit of impetigo, almost like a little, and they come in clusters, right? Almost like a little, you know, outbreak sometimes. It's one of the most common skin infections that we see in children. It's highly contagious and most commonly affects young children and infants, especially the preschoolers. There are 3 types of impetigo that you might be aware of: your non-bullous impetigo, your bullous impetigo, and ecthyma. The most common form is the non-bullous impetigo. Am I going to be given a time? Check. Right, so the most common is your non-bullous impetigo, also called impetigo contagiosa, accounting for almost 70% of cases. And you have to be very high index of suspicion, because they'll fool you. You know, it doesn't quite look like the classic impetigo that, you know, you're taught in medical school, and then the children end up with very serious complication. I had a child who died from impetigo, right? She had impetigo for her arm, and she, you know, she had GSAT exam at the time. Father took her to exam, and she came to hospital with a cellulitis of the whole arm, and she developed multi-organ failure and died from impetigo, right? So the etiology of impetigo varies based on the climate and is evolving over time. In temperate climate, it is mainly caused by Staph aureus, while just 5 to 10% of episodes are caused by strep, group A strep. All right, so what does that look like to you? If you were to, anybody, what it looks like to you? Yes? So that is impetigo, that is non-bullous impetigo, right? Remember, I tell you, it can fool you. Looking at this, you know, don't quite look like, you know, what you would expect an impetigo to look like. And of course, that is the classic bullous impetigo, right? That, you know, we are taught to look out for. But the fact of the matter is that this one is actually the more common one that we see. All right. And what that looks like to you, that is ecthyma. All right. Okay, so just a little summary for impetigo that involves limited skin area. Topical antibiotics is indicated, right? And of course, you know, you have various options available. The most effective oral antibiotics for impetigo are the anti-staphylococcus penicillin, which is your amoxiclav, And of course, your cephalosporin plays an important role here. Erythromycin as a macrolide is not as effective in treating your impetigo. So topical indicated, but you may have to use orals. And I mean, in my personal practice, you know, you really have to be on top of these children. You start the topicals and they come back the following day with, you know, something all over the chest. And you put a little topical on it, and then, you know, because they scratch themselves and they, you know, and stuff. And of course, it's spreading to other children in the class. So you have this massive outbreak, right? So in some instances, you will have to go quickly to using your oral antibiotics. And of course, a lot of complications as we spoke about, you know, your cellulitis, sepsis, multi-organ failure, post-strep glomerulonephritis, right? Is a one of the major complications, and we see quite a bit of that for those who practice in hospital medicine. And the triple S or the quadruple S, your staph scalded skin syndrome. Look out for that. We see a lot of children. I mean, not a voluminous number, but when they occur, they're very, you know, overwhelming. You know, classical parents will tell you, you know, I touch his skin and his skin just shed off in my hand, right? So when the parents call and tell you something like that, and he might have this crusted thing around his nostril, that's stuff called scalded skin, and you have to treat it aggressively, or that child is going to, you know, suffer serious complications. All right, so I think this is the last two, bacterial sinusitis. You know, I think Marsha will go through this, but acute rhinosinusitis is characterized by inflammation of the paranasal sinuses, common complication of a viral upper respiratory tract infection and allergic rhinitis, and it usually resolves spontaneously. Acute bacterial rhinosinusitis occurs when there's a secondary bacterial infection. The diagnosis of acute bacterial sinusitis can be made clinically in children with symptoms. So some, you know, doctors will do your CT scan. I think in the older days, they used to tell us, you know, make sure you scan the patients, but you can diagnose it clinically. All right, so you have your daytime symptoms, your nasal symptoms, and of course, one of the following, no improvement after 10 to 30 days. So this is a common presentation in children, right? So, you know, there are some guidelines. If the patient is ill appearing, you know, with temperatures greater than 39 degrees with a purulent discharge, but 3 or more consecutive days, or they have worsening respiratory symptoms, new onset headache and fever, you have to consider an acute bacterial sinusitis and treat accordingly. So antibiotics should be prescribed in children with severe, worsening, persistent acute bacterial sinusitis. Outpatient observation for 3 days is also an option in children with persistent symptoms. Amoxicillin alone in combination with clavinonate is the first-line antibiotics of choice. However, alternatively, a second or even first-generation cephalosporin, such as cefuroxime, can be used to treat these children. All right, so I think this is a final condition we'll look at, and it concerns pharyngitis. Pharyngitis is group A, it's caused by group A strep, right? And it's a leading cause of tonsillar pharyngitis in children. One of my patients called me last night to say that she has a 2-year-old child who presents with a red, angry throat and difficult to swallowing. And she has a runny nose, and she asks if she needs to start antibiotics right away. What would you recommend? Start or don't start? Start. All right, so I told her not to start. I feel bad because all of you say start, right? But the fact of the matter is that the bacteria that causes a pharyngitis, the group A strep, affects which age group? Our school age children, right? So it's very unlikely to have a 1-2-year-old with group A strep infection of the pharynx, right? Group A strep is an infection of, you know, a older child, you know, a 5-year-old and above, 5 to 15 we classically say, right? And on top of it, she has a runny nose, right? So there are certain, presentation that can guide you. So it's common in children 5 to 15 years old. Of course, it's a school-age child. It's a common cause of pharyngitis in younger children. And of course, you can have various, complications, suppurative and non-suppurative complication. Your non-suppurative complications are like your, your renal disease, and of course, rheumatic fever is what most of us are very concerned about. Have anybody heard about the center, criteria? Center. So center basically is saying what I said to you before, right? So if you have a child who presents with, little aches and pains and muscle cramps, and he's having a runny nose and, headache and that sort of thing, he doesn't have any lymph node around the neck and stuff, that sounds like what? A viral infection, right? So that's basically what the center score is about. Basically, they look at certain presentation in the child and assign a score. So if you have a runny nose, you get almost a negative type of score because that looks more viral. If you have, a exudate on the tonsil and you're having a high fever, not having any muscle cramps and that sort of thing, you get another score, and they add it up, and that can give you an idea that, this is more likely to be group A strep or a viral infection, and hence to treat or not to treat. All right, so you can review the center score. So penicillin is a treatment of choice. Penicillin resistance has not been documented. All right, everybody? Almost said brethren. So it has not been documented. So therefore, it's what is recommended. But cephalosporins are recommended in children who cannot tolerate penicillin or are allergic to penicillin. I have another child who called me some time ago. She started penicillin and the child just don't tolerate it, not tolerating it at all. Of course, because this is strep sore throat is such an important condition for morbidity and mortality. If you have a child who has mild or non-IgE mediated penicillin reaction, for example, a rash starting 5 days, a couple of days after therapy, you can still use a cephalosporin. Does that sound dangerous? You actually can, right? And you remember that slide that I showed you with the side groups, with the group in the middle, and then the side groups. The more advanced the cephalosporin is, the less similar the side groups are to penicillin, right? And what we were taught in school is that 10% of cross reaction. Nobody remember that? If you have a penicillin allergy, then there's a 10%, likelihood of cross reaction with cephalosporin. Yes, right. So what we actually, that is not the case, really, right? So the percentages is very low, especially in the more advanced cephalosporin, 5%, and sometimes as low as 1%. Right. So you can, if you have a mild reaction, you can still use your cephalosporin. All right, your second generation cephalosporin. And I've come to an abrupt end. I didn't realize that I was finished. So in summary, children get sick quite a lot. You know it, right? In your practices, that the parents are frustrated and you're frustrated too, right? So they come to your doctor, what am I to do? My child is sick every single week, right? And they want a magic bullet. So they come with these, viral infections and that sort of thing, confusing respiratory infections to us, and they're forcing you to treat. Huh? You have patients who force you to treat. Yeah, they bad you up, to give antibiotics, eh? And you have to kind of just hold their hands because it's frustrating. You understand? Meticulous taking of, a history that we're taught in school, doing your examination and appropriate evaluation is necessary to determine the right course of action. And when antibiotics is indicated, cephalosporins are actually a good option in some cases for first-line therapy, and they are safe and effective and well tolerated in children. Thank you very much for your attention.
Thank you so much. Can you stay down?
Mic check 1 2.
We have some questions
Mic check
and
1 2.
answers.
I thought it was afterwards.
No, after each presentation. So we invite persons who are here, present with us, as well as persons online. Some will be monitoring those questions and be reading those questions accordingly. So if you do have any question, we invite you to go to the center of the room where there's a mic, or if you don't want to, we have a room in mind. So whichever one.
While we search for persons online or in the room, first question. In our setting, where a well child may not be able to closely follow up because of social circumstances, is the SNAP treatment still indicated?
I was a little confused because I didn't see who was reading the question.
I'm reading it, Dr.
All
Price.
right. Right. So say it again for me, please.
Yeah, in our setting where a well child may not be able to closely follow up because of social circumstances, is the SNAP treatment still indicated?
Yeah, as I said before, you know, you have to individualize the therapy. You know, we have to be cautious at the same time, because you might have a child who comes in and he has gotten, you know, 5 courses of antibiotics, you know, for what you know is a viral infection, right? So you really have to individualize, and you really have to emphasize to that parent, you know, the importance of the follow-up. But yeah, I mean, if you have a high suspicion, or you know, if you have a low suspicion, you're not able to follow up, you may have to you know, defer to treating. But please emphasize to that parent, because as I said, we are seeing a lot of children with serious resistant organisms. Some of the time we're not able to document what the organisms are. Example, you know, with pneumonia, it's really very difficult to document organisms in children. But we see the resistance. We start a particular antibiotics which you used before, and you know, nothing. All right. So emphasize to them, you know, do your best in getting them to come back for follow-up.
Hi, good morning. You have a child less than 18 months. You suspect the person has a viral infection, chest infection, and you don't want to start antibiotics, so you recommend to go on, you know, the usual fever and whatever. But the temperature remains at 103. It fluctuates 103, 99, 103, 99 for 3 days. When do you start your antibiotics?
All right, so there's actually, you know, an approach to the febrile child. You know, and we have a lot of those, you know, presenting with these fluctuating temperatures. We need to kind of determine, are they sick or are they well, right? You know, a child comes into your office, a lot of us, you know, based on experience, they walk in and you know that this child is unwell. This child, you know, look sick, he look bacteremic, he look like he needs to be sorted out. If you have that child from the go, all right, so you need to investigate that child appropriately. And you can start by doing a CBC, right? You're doing a CBC, you can do a, you know, a CRP, look at the differentials, look at the absolute neutrophil counts, and those can help to guide you. You know, the child is having that sort of pattern. You do the CBC, the white cell count is 6, you know, or the white cell count is 3, right? You have experienced that, right? Where you see these viral looking children and you do their white cell count and it's very low. You understand? But they are well looking. Because we know overwhelming sepsis can cause a low white cell count. But they have a white cell count, but they're tearing down your office and, you know, doing all of those funny things inside. You can observe those children, right? The ill looking one, refer them, right? They may need a blood culture, you know, and start something. But if they're well looking, even with the fluctuating temperature, you know, observe. 3 days pass and they're still going on, or they get looking more ill, then do some investigations on them. All right. And of course, there's something called a radiological pneumonia. All right. So if you have a child who presents with this high fever, you do the white cell count and it's greater than 25,000. you do a chest X-ray on that child. Right? A lot of times you listen and you don't hear much, and when you do that chest X-ray, you see this big, white out, in that area, and that child would need antibiotics.
Good morning, Dr. Price.
Prof, don't ask me any hard questions, okay?
You mustn't do this to me. I'm a simple man. My name is Albert. I have two questions for you. One is very simple. I've been in practice for 40 years, so I'm quite familiar with all the problems that you presented. But with respect to the choice of antibiotics, many of my patients are very concerned about the taste. And it's a point which you really need to help me with, because when I compare A with B, we won't name the B, it tastes a little different from the A, even though B might be the one that one would recommend. Is there any way one could modify the taste to make it more acceptable to the youngsters?
I told him not to ask me the hard questions, All right. Yeah, the children, it's difficult. It's a challenge. It's one of our major challenge sometimes, eh? So we advise the parents to do, little tricks, but some of the children are so wise, right? I've asked a parent to mask the medication in a little juice or a little honey for the appropriate age category. And the mother tells me that the child stopped drinking. Right? And another one says she wants to see the bottle, so you try, you give them medication, you wash it down with a little juice quickly. You can use smaller quantities of the medication and mix in, a little juice or a little honey, the honey kind of thick and stuff. Remember, we don't use, unprocessed honey in children of a certain age group. So you can try strategies like that. You could try little reward strategies, right? So you give them something that they like and that sort of thing. And you twin certain things together. You really have to be creative, but I can't tell you it's easy.
No problem. The next question is far more difficult. I really need you to listen to my talk this afternoon, because you mentioned a heartfelt concern about forcing to treat, which suggests that you're being, not you, but we are being coerced into prescribing antibiotics inappropriately or even misuse. We're going to discuss this afternoon. But I want you to, you have time. You should have spoken for 50 minutes, so you have a long time.
Oh,
yeah.
Thank you.
So I want you to help us to understand how you help your patient to get involved in shared decision making, because that's the critical thing. How do we work as a team to maintain the patient autonomy, but at the same time doing no harm?
Yeah.
Over to you.
Yeah, thank you. And I like that question, because well, I deal with it every day, and I'm sure you all deal with it every single day, even up to the last time I was in office, right? And especially with your new clients, right? So they don't know you, okay? And the ones who trust you, they will, right? But if they don't know you, the new ones coming in, they try to force your hands. But the fact of the matter is that they try to do the forced coercion because I find that they don't understand. You understand? So they have a concept in their head that they got from grandmother, or they got from, and grandmothers are powerful, eh? So I use Jamaican grandmothers, very powerful. Well, I think all over, all over. So I usually ask them to, what tell me what exactly are you, thinking, eh? And they will explain to you, and you're surprised that what is in their head. And even when you explain to them, you see that they don't get it. At the end of your discussion, they say, so what antibiotics you can give me, doctor? Right? You're like, what do I do? So you kind of negotiate with them. You know, you kind of say, all right, let me tell you what we're going to do, right? I have a number that I give them and they can contact me and everything, right? I said to them, all right, we're going to go, 24 hours, right? And we're going to go 48 hours. You're going to send me a message, right? Tell me how the child is doing over the 24 hours, and then I'll advise you what to do. And then 48 hours, so you have to try different strategies. And what happens is that when they do that and they realize that, it works, right? I mean, the child settled down, the child, improve without, can I tell you, last week I went down the road and the child was sick and I got antibiotics and he got better. You heard that all the time, right? You try to tell them that he would have gotten better anyway, right? But they don't get it. So you kind of hold their hands and guide them, tell them about, the side effects of antibiotics. And I tell them scary stories. Sorry, Prof, I tell them, right? Scary stories I thought with children. We had a child who we had to transfer to university sometimes ago, and they couldn't find any antibiotics to treat the child. None. The child was resistant to everything. You understand? So you try to, to use some of those things to guide them. And then when everything fails, you pray. All right? Yeah.
Hey, Dr. Price. Question from online. Any indication for azithromycin?
For azithromycin?
Yes.
Certainly. We mentioned, your community acquired, you walk in pneumonia, your school age child presenting with, your cough and low-grade fever, and that sort of thing, and you suspect a pneumonia, then it's usually atypical, your mycoplasma and your chlamydia pneumonia, and azithromycin is indicated, for those. All right. So of course, otitis media, their azithromycin is not that good. Definitely not for a UTI, right? And of course, your skin staph infection, not ideal either. All right.
All right, thank you so much. Next question. When treating children with antibiotics, would you routinely recommend that they're given probiotics to replenish their gut flora?
Well, I don't know if there is any routine recommendation for probiotic use. I must say I do use it at times because I've studied the usefulness of the integrity of your internal flora. But I don't know of any studies or anything that I've suggested that it should be used routinely.
Okay, another question here, thanks. For asthmatics who are well controlled, what are the precautions to take to prevent asthmatic attacks as a result of viral or bacterial URTI?
Say that again quickly.
For asthmatics who are well controlled, what are the precautions to take to prevent asthmatic attacks as a result of viral or bacterial URTI?
Okay, so we're going into another another discussion. But just to say, work with your healthcare provider. There are some children that we actually recommend starting your prophylactic treatment if they're not on it or ramping it up for asthma during the flu season or at the onset of a respiratory tract infection. All right, so that is actually recommended. All right, thank you.
Wow, thank you so much, Dr. Price. Felt like you were all back in medical school, I assume. It was nice to see all the organisms and so displayed. Just for, I was listening to Professor Bailey, your question about the taste. I was actually listening to it because that's one of the best features of our line, the fact that it tastes awesome. And I can vouch for that as a mom of 3. My youngest is 2, and I have a 4-year-old as well who is on the spectrum. And it's very hard to get them to take medication. And this one is one of the best tasting ones. All right. So you shouldn't have any problem at all with that one. Z. All right. So we're going to move right along into our coffee break. Our coffee break is going to be next. And since we're going ahead of schedule a little bit, we're going to restart at 10 o'clock. So we're going to have the coffee break now, and we're going to restart at 10 o'clock. Just want to remind everyone that is here to just log in and register so that you can get your credits. Okay, if you haven't done so, please just take the time now during the coffee break to log in and register so you can get your credits. Okay, everyone's clear? All right then. All righty. Online. Yes, you have to register online. Just log in. Right. All right.
Sandoz is the global market leader in generic and biosimilar medicines. Whatever we do, we put the needs of patients first, making high-quality, cutting-edge medicines accessible to more patients, whenever and wherever they need them, and at prices they can afford.
Hey, this is the new way to support your treatment access. Say hello to the Saludando Plan. Would you like to know how the savings and discounts mechanics work? Let's take a look at Cece's case. She goes to her favorite pharmacy to buy the medicine her doctor prescribed. At the pharmacy, Roger kindly assists her and talks to her about the new discount Saludando Plan by Sandoz. Roger signs her up very quickly, and just like that, after buying her first medicine, she will already be saving. Some days later, Cece returns to the pharmacy for a new purchase. Roger greets her with the great news. He checks the Saludando website and sees that she has accumulated savings. He tells her the balance, and now she decides. She can either use the accumulated balance or just a part of it for this purchase. The discount will become effective, and she will only have to pay for the price difference. If she decides to keep saving, she'll be able to use the balance in her next purchase. What happens if she has an accumulated balance that is higher than the product price? Saludando works using immediate discounts. It reduces amounts lower than the full price of the invoice. Cece can use the accumulated amount closest to her invoice, and the rest will be kept in her balance. Saludando offers a benefit with every purchase, and not just once in a while. It can be used from the first time you accumulate, and you don't have to make a big investment until you can have a minimum to be redeemed. Yes, it's more practical. Yes, it's immediate. Saludando Plan, a friendly plan that supports you and says hi.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotics site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. Sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundal facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
With no place to go. All I used to do, he will show me the way. It's not there when I want it can't happen anyway. When I kneel down on my knees and pray, I know my prayers are answered because I got faith. Thank you, Lord. Thank you, Lord. Thank you, Lord. Thank you, Lord.
This is a brief history of B&H, everyone's favorite photo and video store. The year was 1973. The Mets went to the World Series. The first cell phone call was made.
Okay, so while we're still having the coffee break,
welcome.
Is it working?
Yes. Thanks again. We're about to get rolling. And of course, we'll invite those who can settle down a bit so we can move forward and move ahead. So at this point, at this juncture, we're going to have another introduction, the second guest speaker, and we'll invite Mr. Wayne Young to come and do the honors. The topic, okay, so just before we go into the second speaker, we are also going to invite you to watch a video of our latest initiative from SANDOZ. It's known as the Saludando program. So afterwards, you will get more instruction as to how you can take part in this new initiative from SANDOZ. So just watch what's going to come up on the screen, and then we can proceed. Thank you.
Hey, this is the new way to support your treatment access. Say hello to the Saludando plan. Would you like to know how the savings and discounts mechanics work? Let's take a look at Cece's case. She goes to her favorite pharmacy to buy the medicine her doctor prescribed. At the pharmacy, Roger kindly assists her and talks to her about the new discount Saludando plan by SANDOZ. Roger signs her up very quickly, and just like that, after buying her first medicine, she will already be saving. Some days later, Cece returns to the pharmacy for a new purchase. Roger greets her with the great news. He checks the Saludando website and sees that she has accumulated savings. He tells her the balance, and now she decides. She can either use the accumulated balance or just a part of it for this purchase. The discount will become effective, and she will only have to pay for the price difference. If she decides to keep saving, she'll be able to use the balance in her next purchase. What happens if she has an accumulated balance that is higher than the product price? Saludando works using immediate discounts. It reduces amounts lower than the full price of the invoice. Cece can use the accumulated amount closest to her invoice, and the rest will be kept in her balance. Saludando offers a benefit with every purchase, and not just once in a while. It can be used from the first time you accumulate, and you don't have to make a big investment until you can have a minimum to be redeemed. Yes, it's more practical. Yes, it's immediate. Saludando Plan, a friendly plan that supports you and says hi.
Hello, right. Good morning again, everyone, to those with us here and online. So my name is Leslie Woolreferon, and I'm just here to tell you a little bit more about our Saludando plan. So Saludando, as Nakia mentioned, is a patient program that SANDOZ has currently, which was geared with our patients in mind. So we know a lot of our patients here locally, a big issue for them is compliance with their medication and taking their medication on time and every month. So Saludando was created with that in mind. You can get more information from the website, which is plansaludando.com. It's on the screen there. As well as everyone here, if you're on any chronic medication, you're encouraged to download the app, sign up for the plan, encourage your patients and anyone else that you know. We do have 12 participating pharmacies currently across the island with Plan Saludando, and they are as follows. We have Victoria's Pharmacy in Kingston, Dean's Pharmacy. In St. Catherine, we have Livewell Pharmacy, Portmore, Lifeline Pharmacy, Benson's Pharmacy, Prescription Plus Pharmacy. In Manchester, we have Gateway Pharmacy, Christiana Pharmacy. St. Elizabeth, we have Drugs and More Pharmacy and St. Bess Pharmacy. And over there in St. James, our North partners, we have Livewell Montego Bay and Value Drug Pharmacy. All right, so I encourage you to scan the QR code, download the plan, and of course, any member of the SANDOZ team will be able to give you more information on Plan Saludando and how this can benefit your patients. Thank you.
Yes. Wayne. I think it's your turn now. All right. So we're going to be waiting on Wayne to come and give the introduction. Our second speaker. Awesome.
Thank you. Okay. Good morning again, everyone. Let's try this again. Good morning again, everyone. I like that. If the coffee break wasn't sufficient enough, we still have more. So you can rejoin the line. All right. So just some in-house matters. Just a reminder, we need your email addresses for you to be granted your CMEs. So please, if it is that you can go online, if you have the link, you can go and register, submit, so we can have your email address, or visit the booth at the back and give your email addresses, all right? Okay. So it's my pleasure to introduce the next speaker. She may not like me after this, but that is okay. I still got love for her. Our next presenter was born in Nassau, Bahamas on August 17th in that blessed year. Her nationality, however, is Jamaican. Dr. Kathy Ann Pate Robinson is currently married and has 2 children so far. I never limit anyone. Dr. Pate Robinson's educational background spans both, don't do that, don't do that, there we go. Spans both locally and internationally, from her time spent at Campion College to the Aiki Health Promotional Foundation in Japan and the Faculty of Medical Sciences at the University of the West Indies. She has her Bachelor of Medicine, Bachelor of Surgery from the University of the West Indies, her Wellness Specialist certification from the Aiki Promotional Foundation in Japan, and her DM and Fellow in Internal Medicine and Infectious Diseases, respectively, from the University of the West Indies. Her postgraduate training and experience includes, but is not limited to, internships at Princess Margaret Hospital in Nassau, Bahamas in surgery, OBGYN, medicine, and pediatrics. Internships in pathology, accident and emergency at the University of the West Indies. Resident in internal medicine at the University Hospital of the West Indies from 2009 to 2014. Fellow in infectious diseases at the University Hospital of the West Indies from 2014 to 2016. Clinical Management of HIV e-learning program, Department of Global Health at the University of Washington in 2023. Just to name a few. To save time, Dr. Pate Robinson is currently an associate lecturer at the University of the West Indies. She's a consultant at the Center for HIV/AIDS Research and Education, aka CARES, at the University Hospital of the West Indies. She's a member of the fundraising committee, Department of Medicine at the University of the West Indies, member also of the COVID task force at the University of the West Indies. Dr. Pate Robinson currently supervises and trains medical students, interns, and residents. She also supervises and/or conducts HIV training and sensitization sessions for A&E staff at the University Hospital of the West Indies. She is a member of the Jamaica Medical Doctors Association, American College of Physicians, HIV Medical Association, and the International Society of Infectious Diseases, again, just to name a few. In her spare time, yes, she does have spare time. In her spare time, Dr. Pate Robinson likes singing, dancing, swimming, mercy. She also does martial arts. So she can hurt you and fix you. Good to have a balance, right? Ladies and gentlemen, please help me welcome to the podium Dr. Kathy Ann Pate Robinson. Thank you.
Yes, some people deserve hurting before healing, right? Good morning, everyone. Are we still in morning? Yes, we are. It is good to see you all here. I'm happy for the online audience as well. And I suppose we should get going. Thank you all for being present, and I hope I don't break your brains. But feel free to ask questions after. Thank you. That's good. Can we advance the slides? Ah, there we go. So, disclosures, and we shall move. Ooh, moving on too fast. There we go, one at a time. So we're going to talk about respiratory tract infections. I must say I'm an adult physician, although I do occasionally get involved in pediatric care, but primarily an adult physician. So, give me a little grace on that one. Or my other colleagues are well-versed in the pediatric population, and I won't overlap much with them. In terms of what we're going to talk about, we're going to spend a little more time on community-acquired pneumonia and just this list of things here. So, this new generational gap that we have. So a lot of us in practice for a little while, we tend to avoid the acronyms, but all the residents and interns call it CAP now. It's no longer community-acquired pneumonia. So for community-acquired pneumonia, we're really looking at a constellation of symptoms in the lower respiratory tract caused by a wide variety of pathogens. You can have your typical bacteria, your atypical bacteria, and your viruses. And as we all have seen in the last 5 years, the viral infections have become particularly challenging, even though we are in this time period where we have limited antimicrobial resources and drug-resistant organisms are also much more prevalent. And the concept of antimicrobial stewardship has really become more significant for us, because in the last 2 decades or more, we haven't really seen many new antibiotics being created or developed, but we're reworking them and adding things to them to make them more effective, but our choices remain relatively limited. And we need to preserve that by using them appropriately and avoiding the complications of inappropriate use, in particular, apart from the multi-drug resistant organism infections, keeping the drugs useful. Because if we kill off our normal flora, which protects us from pathogens becoming part of our local body community, then we are going to increase the risk of infections with those drug-resistant organisms. And it's a vicious cycle. And then we share them with our close family because they're in close contact with us, and then we no longer have an issue just for our future potential risk, but for the future potential risk of all our family members and those who are close to us. So, sharing in this case is not necessarily caring. And it's important to mention that in the vast majority of pneumonias, there isn't an identified causative organism. So about 62% in some studies, you see negative blood cultures, negative sputum cultures in terms of pathogens being identified. But at the same time, there is good clinical and laboratory evidence otherwise of infection, just that we haven't been able to pin down the causative organism in those cases. And so we have to look at empiric therapy as the way we go in the beginning, and we may not be able to switch to targeted therapy because targeted therapy may not be something we can determine. So when we look at respiratory tract infections, we have to think about why it's important. And I couldn't put all the epidemiology on the slides. I'm sorry, there's a lot to know, and respiratory tract infections are too common to ignore. One of the deadliest diseases of infectious etiology remains high on the list of causes of death globally. And in 2019, the most recent reports that I could find, over 2 million deaths globally for respiratory tract infections. For lower respiratory tract infection, usually more than others, but generally speaking, respiratory tract infections. And since 2019, COVID happened. And since COVID, a lot of the resources globally have been taken up looking at viral infections, looking at COVID specifically and long COVID. And so that's consumed a lot of the research that has been going on. But we are branching out again, and there will be a lot of new papers published between this year and next year in all the areas that were kind of ignored in COVID, and that includes some of the bacterial respiratory tract infections. And we have to think about those who are most vulnerable: elderly, infants, and children, either because of a developing immune system, a reduced exposure as yet for the children to a wide variety of pathogens, so they haven't developed their immunity. And then for the elderly, we have immunosenescence, we have waning of immune function, waning of that ability to protect the host, and that leads to an increasing vulnerability. And that vulnerability increases to some organisms by age 50, some by age 65. And then once you get into your 80s, the risk of mortality associated increases significantly. So these are some of the typical pathogens. They shift around, you know, in position sometimes, but Streptococcus pneumoniae is the prototypical lower respiratory tract bacterium that we are going to fight. This is why there are multiple strep pneumonia vaccines available, which the average person doesn't consider themselves to need. But if you are over 50, you should consider vaccination. And if you have any particular indications like sickle cell disease, you have any immunocompromising conditions, you should consider vaccination for yourself, for your family, for your patients. And please bear in mind that if you are indicated to have both types of vaccine, the conjugate vaccine and the pneumococcal, the polysaccharide vaccine, then you should get the conjugate first, because you get a better immune response having the conjugate first. But the generally available polysaccharide vaccines cover more species than the conjugate. So in somebody high risk, for example, somebody going for a splenectomy, it is important to get both vaccines, but you would start with a conjugate and have the polysaccharide vaccine afterwards. So when we look at causes of death, as I mentioned, you know, we haven't had good updates, but we will hopefully by next year, or maybe by the end of the year. Lower respiratory tract infections has stayed in the 4th or 5th, maybe 4th to 6th position for the global data for a long time. And in many countries, that is particularly the position that we're at. We still have a lot of other things vying for 2nd and 3rd place, but even though we have transitioned in what's available to us, we're still not able to get lower respiratory tract infections off the top 10 causes of death list. And there are many factors for that. And so it's one of those things that we have to be very aware of and treat efficiently and effectively. And because it's going to happen again, we need to use our antimicrobial agents very carefully, because we will need them over and over. So let's take a look at the respiratory tract. You all know what the respiratory tract looks like. I mean, this is a very ugly picture, even though it's pretty with colors. And our air inflow comes through the nasal cavity, comes through the mouth, the oral cavity. We don't have a direct connection through the ears, but the middle ear cavity is connected to the pharynx. And we have some protective factors, including the immune function in the respiratory tract from top to bottom. But we also have things like your epiglottis, you have your larynx, you have different functions that prevent germ entry. But once the air is entering and there are germs in the air, those germs are going to get into various areas of your respiratory tract. And if we have physical factors that are going to increase the risk of infection or reduce clearance of germs, then that is also going to increase our potential for challenges. And that has a particular impact on upper respiratory tract infections, which we will mention a little bit later. So we want to have a healthy respiratory tract. We want to preserve our normal flora. We want to make sure our mucus is running freely and not overproduced. And so things like managing allergies becomes important, because if you have increased secretions, they're thicker, they don't move very well, you already have germs in place that take advantage of that situation, and then you set up a sort of vicious cycle where you promote germ growth and you promote them growing in place. And that increases your risk of infection because you have more germs available to create an infection. So the physical characteristics and the management of the other issues that we have with the airways, and I feel like in our country of Jamaica, we have the majority of our population has chronic allergic rhinitis. Most of us in this room have probably had challenges with that, what people generally call sinus problems. And if we don't manage that well, then we end up going through a vicious cycle of recurrent infections. And most of us, if not all of us, have probably been treated with antibiotics at one time or another in our life when we perhaps didn't need it. And so we do need to pay attention to the background physical characteristics. So that's upper tract, and then we have lower tract. And the challenge is that lower respiratory tract infections, because the lower respiratory tract is more protected from outside influences, it is, a relatively privileged space. We don't have as many germs getting down into the lower respiratory tract, but when they do, they have ease of access to the general circulation and to deeper seated infections than we would otherwise have. And that means that the risk of needing advanced care, hospitalization, having more severe infections increases with lower respiratory tract infections. And so we do pay a little more attention to them. And if you look at this slide, it's kind of giving an idea of what are some of the common organisms from a bacterial perspective, more so than others, that we tend to see. And some of the viruses are mentioned. There are thousands of viruses that can play a role. And currently, at least in many countries, we can't test for all of them. There are some panels that are available to do things like fluorescent antibody testing, but they're not readily available. And so we are often treating even the viral infections empirically, and most of those are supportive management. So we could, from an upper respiratory tract infection, be talking about things like your common cold or your rhinosinusitis. You can have croup, which I suppose that's more something that you will diagnose in children. Whooping cough, we've recently in the last decade had increased outbreaks of whooping cough because of lower vaccination rates, especially in places like Canada. We've had increased outbreaks of things like measles, especially in the UK and the US, because of vaccination challenges. We are somewhat protected here in Jamaica to a great extent because we have been able to maintain more than 95% vaccination coverage in our pediatric population, and we are slowly improving in our vaccination offerings to adults. But this is something that we can still improve on, and we do need to maintain that because it protects us from some of these things that we may not have the economic ability to deal with a large-scale outbreak. So severity scoring. So we're going to talk a little bit more about the lower respiratory tract infections or community-acquired pneumonia in particular now, although we'll mention some things about hospital-acquired infections, or at least a comparison to some extent. Severity scoring is important because you want to determine which patients are more likely to need hospitalization, which patients are more likely to end up in the intensive care unit requiring perhaps ventilatory support or advanced care, and be able to stratify that as early as possible, because you don't want to keep somebody in the community who is high risk for deterioration and a poor outcome, because we all want our patients to do very well. And so, oh, that disappeared so quickly. Hold on. Do me a favor, I'm sorry. I have to go quickly for it to move and show you. Right, so the one on the right is the pneumonia severity index. The one on the left is a CURB-65 scoring system. There is no scoring system that's perfect. All of them have their flaws, they have their challenges, but they do have a good evidence basis for helping us to stratify how severely ill a patient would be. These are primarily used in adults. I'm sure there are other scoring systems, as some mentioned by Doc before, that are used in pediatric cases. But the CURB-65 is sort of a very easy one because it's 4 or 5 things that you look at. The PSI, or the pneumonia severity index scoring, is a bit more involved and takes a little more time because there's more information that you have to gather. But the point of all of them is that we're using them to try to determine who can be treated as an outpatient safely, who can't be, and then there's always a middle group that requires your clinical judgment to determine whether this person is likely to be high risk or likely to be low risk, because there's always somebody who falls in the middle on the borderline and you're not quite sure what you should do. And depending on how well you know the patient and their previous history and their individual challenges, then you may be better able to stratify them in one category or the other. So this is something that can be useful to help from that perspective. And I would encourage us, when we have a patient who has features of a community-acquired pneumonia, to consider risk stratifying them in that way so we can determine if they're high risk or low risk. And if they're high risk, then that would be the point at which you consider maybe referring for a hospital-based assessment or a tertiary care institution that would have more emergency services available, because they may be at increased risk of complications, increased risk of rapid deterioration, or requiring advanced support, oxygen therapy, and otherwise. All right? So when we look at treatment options, we want to treat the organisms of concern. Now, we know that there are a lot of organisms that form part of your normal flora, but there are also a lot of organisms that are airborne, collected by fomite transfer, meaning small droplet transfer, and these organisms are the ones that we're going to be targeting. The vast majority of respiratory tract infections do happen because of viruses and strep pneumonia. Those are the top 2, really. And then your viral infections, you're not going to use antibiotics for. The average respiratory virus does not respond to the usual antivirals. We do have drugs targeting influenza, but we don't often know if we have influenza, and a lot of patients don't get tested. So it really comes down to, do you have clinical suspicion of an influenza-like illness and the patient is high risk, then you may treat presumptively and use an antiviral agent. We don't have many available, but there are some available. They can be accessed through the Ministry of Health, and this is something that you can check out beforehand so you know what the process is to be able to access that for your patients if needed, because that can sometimes be a route through which you can reduce the severity and perhaps prevent your patient from getting into the hospital system because they are able to recover a little bit better as an outpatient. So generally we talk about treating typical and atypical organisms. The typical organisms being more like your strep pneumonia, and the atypical organisms being more like your Haemophilus influenza. So the strep pneumonia, we're going to use primarily our beta-lactam antibiotics. And that's going to be similar to what you see here. And I'm going to tell you a little bit more about the beta-lactams in a short while. But generally, that's your penicillins, your cephalosporins, and there are other areas such as your monobactums and your carbapenems, which would not be utilized in outpatient therapy, but more in the hospital setting and if you have drug-resistant organisms. And so this, and you see here, there are 3 different societies that are mentioned here. The American guidelines tend to skew towards the data that they get for their patients, whereas the guidelines from the European societies will be based on their population data. We don't always have that robust data in the Caribbean and Latin America. Perhaps Latin America a bit better than the Caribbean in general. And so we might not always be able to target what we're seeing in our population because we haven't fully identified it. But generally speaking, there is a lot of overlap between these, and that applies to most populations unless there's specific risk factors in a particular region. And we don't really have much of that. So any of these approaches can be utilized, and they're very similar. And the data globally is getting narrower. It's all looking a lot more similar for the most part. So when we look at duration of therapy, we have to go back to the whole concept of hospital-acquired versus community-acquired versus healthcare-associated, because for a few years there was this category, healthcare-associated pneumonia, which was, you know, if you access healthcare at, say, a dialysis unit, or you're frequently in the healthcare setting, but you've not been admitted to the hospital, then that was thought to have an intermediate level of risk for a hospital-acquired or nosocomial organism that would be more likely to be drug exposed and therefore drug resistant. That's kind of been thrown out with the bathwater now because there isn't, with further studies, there wasn't a significant difference between healthcare associated and hospital acquired. And so we kind of got rid of the category healthcare associated infection. So we really look at community acquisition and the community germs, which we expect to be more sensitive, which we expect to be particular ones that you see in the community, as opposed to the drug exposed organisms, which will be slightly different in a healthcare setting. And one significant change in the recent guidelines in the last couple of years is the reduction of the treatment duration for an uncomplicated lower respiratory tract infection to 5 days. And that is if you have a low level of severity, which is where your severity scoring comes in to assist you with determining how severe an illness you're looking at and whether the patient is clinically stable with a good early response to treatment. So when you have a low-risk patient who starts your empiric regimen and they are clinically stable and showing signs of improvement, that patient may be a good candidate for a 5-day course of therapy from an adult perspective. I don't know what the pediatricians will say on that one, so I'll defer to them there. But from an adult perspective, we have shifted globally to 5 days of treatment instead of 7, 10, or 14 days, unless it's indicated. So if you have a more severe pneumonia, if you are having a less favorable response to treatment, if the patient is not clinically stable, then you're going to treat for a week. And if there are significant risk factors, if there are additional complications, then you may need prolonged therapy. So example, if you have lung abscess, or you have multiple lung abscess, which we see, for example, in Staph aureus, when you have lung infection associated with the bacteremia, you will have to treat for a longer period of time because the complications may take a longer time to respond to treatment. For example, you know, an abscess, you have a collection of purulent material that antibiotics don't penetrate. So you will not be able to effectively cure that with a short course of therapy because the center of the abscess would not be receiving treatment. So the germs would be viable and able to break out of control and come back after a short course of treatment because you've only killed the ones on the surface. And so these are things we have to think about sometimes when we're looking at how long we're going to treat our patients and what's required. And there are patients with collections or complicated diseases that are clinically well and may not enter a tertiary care institution, may not be admitted to hospital for treatment and may get outpatient therapy. And sometimes you know, some of our patients are very afraid to go to the hospital. They feel that if they go to a hospital, they may die. That happens. And then you may have to creatively manage a patient like that. Although if they're high risk, we always do our very best to try and get them into the appropriate level of care that will save their life and prevent complications that may reduce their future function. So generally, from an outpatient perspective, we're going to, even with the inpatient perspective, we're going to start an empiric regimen. As you saw before, for community-acquired pneumonia, we're going to look at a beta-lactam, usually a cephalosporin or a combination aminopenicillin, and then we're going to use something that's going to give us atypical coverage. So then that usually ends up being a macrolide or one of the tetracyclines. It is possible to substitute with a fluoroquinolone, but because of the broad spectrum activity of fluoroquinolones, like your ciprofloxacin and your levofloxacin, we are very cautious with using them in the average patient because we want to preserve our normal flora, not kill unintended to be killed germs. And then we also want to save the extra spectrum of activity that those drugs have against things like your Pseudomonas and other germs and nosocomial infections, because if you are already exposed to them, your risk of developing resistance in your background population of germs is higher. If you then get a more severe infection and require treatment, those drugs may not be available to you anymore because they may be ineffective because you have resistance present. So it's very important to think carefully about the patient you have in front of you. Although if you do have sensitivity to beta-lactam, say you have a penicillin allergy, a cephalosporin allergy, then those clients may need something alternative, and so a fluoroquinolone may end up being your best option. So it depends on the person you have in front of you. And we always try to, as best as possible, look at patient-centered care. What's appropriate for this client in front of me? Is this appropriate for them? Is this going to be the best choice? Is it going to increase their risks for the future? And as you see here, if you have someone in the community who really should get community care for their infection, but they have comorbid infections, maybe they're an uncontrolled diabetic, maybe they have chronic obstructive pulmonary disease, they're a smoker, you know, they've recently been exposed to antibiotics, you may have to expand your coverage for organisms that you were not initially thinking of covering. And that's when you start to mix and match, or sometimes just get help. And you can always ask your pulmonologist, your infectious disease specialist friends, and they can provide some assistance from that perspective. So we don't see a lot of cystic fibrosis in our population, but that is a bit of a special case. We do have a few people in Jamaica who have it, and they would usually be managed by the pulmonologist. But you do have to expand coverage because they do have other factors that are playing a role. So we're going to look at some specific combinations of situations. So if you have a patient who has no comorbid illnesses, they're previously healthy, they're younger than 65 years of old, and these are all for adults, I'm sorry, and they have not been recently exposed to antimicrobial agents in the past, usually 90 days or more. They have no risk factors for a methicillin resistant Staph aureus, and we do have very low rates in the Caribbean as yet, although, you know, we are getting closer to seeing rates of 5% from time to time, but we haven't gotten there yet. So we don't routinely treat for MRSA regardless. Or you think that they may be at high risk of having one of those more water-loving organisms like Pseudomonas. As long as those things are not the case, then an amoxicillin clavulanic acid combination may be appropriate with azithromycin. It may be appropriate even to use your cefuroxime, a second-generation cephalosporin, because it will give similar coverage. Although we know that it's not as good for oral anaerobes, but it does have some coverage. Clarithromycin as a macrolide is an alternative for your atypical coverage. And I do want to say something about azithromycin and clarithromycin. So there was a very interesting study, again in the pediatric population, looking at resistance to macrolides. And they did find, this is many years ago, I don't remember exactly what date, but if you have questions about it, I can help you look it up later. So the study was showing that in the Canadian pediatric population in some counties, they were seeing increased rates of macrolide resistance. When they assessed the cause of that, they found that this often happened in places where they were using azithromycin as their macrolide of choice, whereas counties that were using clarithromycin more commonly did not see that. And more studies were done to look at this issue or this phenomenon and evaluate it. And one of the things that was found is that with azithromycin, because you have a more depot effect in the tissues where you have a prolonged presence of the drug, you then get this prolonged persistence of subtherapeutic drug levels. And that can increase, not bactericidal levels of drug that increase your risk of resistance in the background population. And so the rates of macrolide resistance for use of things like azithromycin with your community-acquired infections like your otitis media and so on, did show an increased rate of macrolide resistance as compared to something like clarithromycin, which does not have that depot effect, is going to wash out of your system faster and not leave you with prolonged low levels of drug. So just to mention that, it doesn't change the price of rice for the average patient, but it is something to consider when we're choosing and when we're using these agents. So what about the patient with comorbidities? Alcoholism is a significant comorbidity for respiratory tract infections and for immune function, so don't forget that group. Any of the major organ-specific diseases, if there's malignancy present, asplenia because that reduces your cell-mediated immune function, diabetes mellitus for many reasons, and those who have used antibiotics in the previous 3 months or 90 days, that's usually the expected cutoff based on studies, then you can consider maybe stepping up from your amoxicillin to your amoxicillin clavulanic acid, or you can, which does have decent activity against oral anaerobes, or you can use it in combination with a macrolide or doxycycline, being the tetracycline that we would use for oral atypical coverage. So what about alternatives? So if a cephalosporin can be used, then cefuroxime would be the one we would choose in our setting because we don't have the other two. So we would use cefuroxime as an alternative to the amoxicillin clavulanic acid in combination with your macrolide or your doxycycline. And then if you have beta-lactam allergies where you would not want to use a penicillin-based drug or a cephalosporin, for that category of client, then you're going to consider using something like your levofloxacin, which would be considered the respiratory, in quotation marks, fluoroquinolone, because there are concerns that ciprofloxacin will be inactivated by surfactant in the lungs, and it's not usually chosen for lung infections. Okay, so the levofloxacin would be your respiratory fluoroquinolone. Moxifloxacin, less commonly used for that, but also available in our setting. Lefamulin, we don't have. It's a new class of drug, a pleuromutilin, and you can look it up. There's not a lot available on it, but it was FDA approved, I think, in 2020, and it is available internationally. We just don't have it here. So let's take a little look at our beta-lactam antibiotics. Generally speaking, there are a lot of penicillins. And we got this from a fungus, right? And then we expanded to everything under the sun. We've manipulated it, we've added to it, we have made it better for different kinds of infections, better for different kinds of drug delivery, and we now have oral agents. And that's important to have because it's more convenient, but do bear in mind that the average beta-lactam, and that includes penicillins and cephalosporins, they don't have great bioavailability. So when you have a more severe infection and you may only be delivering about 50% of your drug to the central circulation, you do want to be careful, because then that may, in some patients, increase the risk of treatment failure depending on their unique factors. Because you do have first pass metabolism through the liver, and you do have a reduced bioavailability after oral dosing compared to intravenous therapy. So anybody who is more vulnerable and you're thinking they're sort of on the borderline of severity, you may want to consider, depending on their factors, lumping them in with the more severe cases and doing a more aggressive therapy just because of the choices you have available to you, depending on what we have. And generally speaking, or amoxicillin clavulanic acid, more commonly used in the adults, but also used in the pediatric population, is our workhorse outpatient penicillin that we use that would provide good gram-positive coverage for your streptococci and so on. You have some anaerobic coverage with your peptostreptococcus and your oral anaerobes, and it does provide decent gram-negative coverage for susceptible organisms, which may be some of your E. coli's and so on. So that's kind of our workhorse drug. If your patient is known to have methicillin-resistant Staph aureus. If some people are colonized with Staph aureus, we do have challenges with that, and they may know that they have been exposed and they have this organism. If you have somebody who has methicillin-resistant Staph aureus, then you're going to probably stay away from the penicillins, because anything that you would want to use for that is likely going to be intravenous. And you would then, if you're going to consider using a cephalosporin, you would be looking at things that we don't have here, which would be ceftaroline and ceftobiprole, which are the anti-MRSA cephalosporins. There is some activity with your 4th generation cephalosporins, but again, I think at one point we did have cefepime. We don't have it available currently as far as I know, although there are thoughts to bring that back in, and cefixime was here and it may be coming back soon. So generally, if there is a concern for methicillin-resistant Staph aureus, it's going to knock out these 2 groups of drugs for us, for the average patient. And then you may be forced to look at something like your respiratory fluoroquinolone, or depending on the severity of infection, that patient may need intravenous therapy and admission to tertiary care unit. Bear in mind that your fluoroquinolones have almost 100% bioavailability in terms of both intravenous and oral dosing. There's very little reduction in bioavailability for oral dosing, so you're not reducing the effective dose when you take your fluoroquinolones orally, and that is helpful when that is an appropriate choice. So oral versus intravenous doesn't matter unless you have reduced gut function and the patient is not able to absorb the drugs. In that case, then oral dosing would be inappropriate regardless of the agent. So do bear in mind that if your client has gut function issues, then none of the oral agents would be the best choice. So this I thought was a bit interesting to mention a few things on here. This is from one of the US pharmacist websites. They often put out very interesting articles. And one of the things, they mention a couple of things to think about, factors when you're choosing and using antimicrobial agents. And, we mentioned a lot of them. We mentioned the route of administration. I do want to reiterate, patient factors. So poor perfusion, we didn't mention, but that can be significant. If you have somebody with a cellulitis who has significant peripheral arterial or peripheral vascular disease, then your drug delivery to that area is going to be reduced. So you may have the right drug, you may be giving it in the appropriate way, but it's not getting effectively to the site of infection. That patient may need in-hospital care because they may need something more bioavailable and more aggressive. So there are multiple factors to consider, and just wanted to remind you of some of these things. So we are winding down. Upper tract infections. We're not going to talk a lot about them, but we are going to talk a bit about them. You are very familiar with the upper respiratory tract and all the areas. You know that upper tract infections, we're really talking about eyes, ears, nose, and throat, right? And the sinuses being in that area. So when we look at sinusitis, I'm sorry, this is a bit small. I should have probably cut it in two and put it, but I wanted to focus on the top because the choices of drug are of a lesser concern, because that all this information is readily available. But it's important to note that for the average patient with an acute sinusitis, you really are not supposed to treat with antimicrobial agents because they don't change the price of rice. They don't change outcome for the average client. For those who are high risk or those who have signs of increased severity, they have a blood-stained nasal discharge, they have tenderness over the sinuses and that sort of thing, then your thought process is a little different. And especially if they're high risk, they're an uncontrolled diabetic, they have other immunocompromising conditions, then you're going to consider that differently. But for the average patient, physical measures and chemical measures to improve clearance of mucus have the single biggest effect on treating their so-called sinusitis or the inflammation that they're experiencing. And so things like steaming with menthol crystals, using saline nose drops, things that are very commonly used on the pediatric side, but you know, adults don't like to do these things. It takes time and we're busy, but doing things like that have a bigger impact on clearing up symptoms and reducing your thought that you need antibiotics when you don't really. And so I want to encourage everyone to just remember that when you're evaluating patients who are complaining of sinusitis. Very often they have an uncomplicated chronic allergic rhinitis. They may have some mucus plugging. They can usually be managed with supportive measures, including improved hydration. One of the things we have to bear in mind is that we're all experiencing global heat, most of us in the world, and that means that our insensible losses of body fluid are increased, and the average person doesn't drink enough water. And so that means that your respiratory secretions are going to be thicker, they're going to stay in place, and they're more likely to be, you know, very heavily colonized with germs because they've been sitting there for a long time. So clearance of secretions is very important in improving that whole process. And it doesn't hurt to use some of the more immune boosting things such as, you know, your omega-3 fatty acids, your zinc, your vitamin C, that provide additional factors that improve immune function in the area. So things to think about for otitis media. You really should not treat if there aren't worrisome features in terms of antimicrobials. Again, remember that the eustachian tube is very narrow and it blocks easily. So if you have a dehydrated patient with thick mucus, they have a lot of allergic symptoms, they're not treating their allergic rhinitis, then otitis media is a risk that they are likely to encounter at some point. But you can reduce that significantly by managing the allergic symptoms and by performing physical measures to remove mucus plugs. So again, antimicrobials in the average upper respiratory tract infection are not required and should be avoided unless they're indicated. And this is just some, you know, recommended treatment protocols, bearing in mind that some of these drugs we don't have. And one thing to mention, I mean, penicillin and cephalosporin and beta-lactam allergies was mentioned in brief before, and I will just add that, you know, the average person who is allergic to penicillin may not be allergic to cephalosporins, and the average person allergic to penicillin or cephalosporins may not be allergic to your carbapenems. And sometimes it is important when you are looking at the patient in front of you to take a very careful history. And very often I find people say, well, you know, I had an allergic reaction as a child. Everybody told me that I'm allergic, but they don't know what happened. And in that case, you may want to consider doing skin patch testing so that you can determine if they truly have an allergy so that you know what your options are. Because a lot of people who have a reported allergy, the things that they experience don't actually equal a hypersensitivity response. Sometimes what they're talking about are physical discomforts or side effects of the medications used. For example, there are many versions of amoxicillin, clavulanic acid that give a lot of diarrhea and sometimes very terrible diarrhea. And somebody may interpret that as an allergy and say, I can't take this drug anymore. Or you, my child, will never get it again. So it's important to be very probing when it comes to allergies and sometimes consider, especially with our limited options, doing some testing to determine if that person is truly allergic. So some things to remember. There's a lot of good evidence available, and it's increasing for shorter durations of antimicrobial agents, for antibacterials in particular, for a lot of different kinds of infections, not just respiratory tract infections. But you do have to classify the patient carefully according to severity to see who really should get these shorter courses of antimicrobial agents. Many respiratory tract infections, especially many of our upper respiratory tract infections, really don't require antimicrobial therapy. And I want to encourage everybody to be good antimicrobial stewards so that in 20 years, we are still able to use the antibiotics that we have today because we don't have much options in the pipeline for new ones. And if in doubt, ask for help. Thank you. That went fast.
Thank you so much, Dr. Pete Robinson. That was a lot.
Sorry.
So, of course, and it was well delivered. It was very, very fluent. And don't be intimidated now. I know you have your questions, so I invite persons to go to the floor, or if you want, I can just come to you. And there are persons online. And by the way, we are edging up to 1,000 persons online. So let's shout out all the people online. Yes. Doing well. So let's just roll into the questions.
Mic test. Oh, it works.
Yes, sir.
Good morning, Doc.
Morning.
I was quite impressed with your presentation.
Thank you.
It will be morphing into my presentation this afternoon. But I want you to clarify something for me. You emphasize the need for us not to overtreat. But you are a little not specific in your recommendation for the low-risk community-acquired pneumonias.
Right.
You just indicated amoxicillin, azithromycin, Carithro, and doxy. But you didn't tell me how long I should treat the patient for.
So if you have an uncomplicated, that was in a different slide, the one with the triangle, but the pyramid. For an uncomplicated community-acquired pneumonia, the recommended duration of therapy is now 5 days.
Okay.
So 5 days is considered adequate. If you think that the patient has some risk factors for perhaps a poor outcome, less robust immune function, they have a comorbidity here or there, you may want to err on the side of caution and give them 7 days. And only if you have specific indications or they deteriorate on therapy and you think there may be a complication, would you be doing further investigation to determine if they need prolonged therapy, like they might have an empyema or something else.
Thank you. You were quite adamant in your concerns about using antibiotics for upper respiratory tract infections, like sinusitis and otitis media. But you didn't tell me what I should treat, what drugs you'd recommend for suppurative sinusitis and suppurative otitis media. Could you elaborate?
It really, in those situations, we're often looking at what's the organism of concern. So you have to evaluate the risk factors for those individual patients. I don't quite know how it goes on the pediatric side. We don't see those suppurative conditions as much on the adult side. And in those cases, we would advocate that you swab the patient or collect samples before starting your empiric therapy so that you have the best chance to collect the causative organisms, or what you hope are the causative organisms, as you start your empiric therapy with the usual agents, to then determine if what you have started is effective, because we want targeted therapy in those settings more so than considering empiric therapy to likely be effective. And we may be looking at broadening things like our gram-negative coverage, maybe using something like ceftriaxone, which would again be more intravenous, or using your quinolone. So those treatments, partly because the risk of tissue damage and loss of function is more significant, those are managed a little more carefully in terms of being deliberate to try to get the best collection of your causative organism while you go ahead and treat. I don't know if that answers your question.
I think it answered. Thank you so much. While we wait on the microphone to circulate, what is your thought on azithromycin being given for up to 7 days?
Sorry, there was a follow-up part to this question. Can we just do that one first, please?
Yeah, that's a very good answer philosophically. In the real world, we do not have access for targeted treatment, because that would be good. But in general practice, if someone comes to you with obvious suppurative otitis media, we do not have the opportunity to go testing to determine best care. What do we do?
So in that setting where you're looking at suppurative as their first presentation, depending on the risk factors and so on, if you don't have enough information to be more targeted, then an empiric therapy in that case may be with something like ciprofloxacin, perhaps with metronidazole, depending on, you know, whether you have sufficient information, depending on the pattern of infection that you have. So you really have to evaluate depending on the factors that that individual patient has. But generally speaking, you would probably start ciprofloxacin as a fluoroquinolone, and then you would consider whether you need anaerobic coverage if you're going to start outpatient management. But I would really suggest that we swap and ask the patient to take it to the lab before we start them, so that if what we've started isn't targeting the organism they have, then we know what to switch to, because the risk for deterioration and further loss of function is very high in those conditions. And also the risk for progression to systemic infection, because they have some reduction either in host protective factors or increased virulence of the organism leading to that pattern of infection. So you have those signs, you want to be more aggressive with managing the patient, because then you could have permanent hearing loss, for example, if it's a suppurative otitis media. You could get a systemic bacteremia and have further complications. So, and Staph aureus, generally speaking, is becoming far more common as an agent of concern for a vast number of infections. We're seeing it a lot more globally, and it's something we have to consider, because then it's also one of those more virulent organisms that's high risk for metastatic infection, seeding other body sites and causing problems. And you can have a bacteremia with that you don't recognize early, because early symptoms of a bacteremia may overlap with a single area of the body, because fever is very non-specific, and some of the other things come with a simple upper respiratory tract infection. There was an online question that there, okay. Not hearing you, sorry.
Hi, good morning.
Morning.
Brilliant presentation. My questions are a bit focused, more on the complicated side. There was one slide that you had for aspiration pneumonia, but didn't give any pathogens. And if you could expand on that. And then secondly,
Mm-hmm.
in terms of Pseudomonas infection, so the patient who's been, well, I'm assuming past say 7 days, been on antibiotics,
Mhm.
and there's a suspicion, especially for aspiration pneumonia, what would
Mhm.
you give? Thank you.
Sure. Thank you. So for aspiration pneumonia, you are looking at your upper gut organisms. So you are thinking that there may be more gram negatives present. You're thinking that there are oral anaerobes present. And in those cases, for the community-acquired organisms, your amoxicillin clavulanic acid combination is actually pretty good to give you a fairly broad coverage of all of those. If you're not going to use that, you may consider using cefuroxime, but if you're going to use cefuroxime, you may want to add some anaerobic coverage and give cheese and peas. The not metronidazole, the other one that starts with C. Thank you, clindamycin. See, my audience is helping me. So you may want to add that for the upper anaerobes.
That's one of the questions that floated in my mind. I don't see any mention of clindamycin, as a matter of fact. And I was wondering what is its role in today's management?
In today's management, well, as you know, clindamycin is an anaerobic agent. It does have good coverage for upper gut anaerobes. It does not typically do well with something like Bacteroides, which is a lower gut anaerobe. And so for clindamycin, we tend to use it for things like that, your upper gut anaerobic sourced infections, which can be a variety of different things that may include a lung abscess, may include your aspiration pneumonias. And so it's a good consideration. One of the things with clindamycin, and there was a lot of fear with it in the early stages of treatment, was the risk of things like C. difficile associated diarrhea and other infections because of its broad spectrum of coverage. But the data in the past decade has clearly shown that the things that are putting us at risk of C. difficile and other associated drug-resistant issues in that perspective are really your high-use broad-spectrum agents, which tend to be your cephalosporins and your fluoroquinolones, because those are the things we use in outpatient therapy most often. So I think cephalosporins, perhaps because they're a little higher use, edge out the fluoroquinolones in the risk of C. difficile associated infections. And then clindamycin, because everybody was so afraid of it and it's not used very often, the rates regarding that are very low. There's been no comparison because you can't compare when you hardly use one agent. But I don't think the risk is specific to any of those agents. If you look at the trends that we're seeing, it's really specific to how broad a coverage are you giving to give collateral damage, to damage too much of your normal flora, so that your opportunistic germs that are present in low levels get to overgrow because they're intrinsically resistant to the antibiotics that you're using. And that's the real issue with that. So there is a place for clindamycin, and it is a good drug, although it is not tolerated at very high doses orally. Generally speaking, 300 milligrams as a single dose would be relatively well tolerated from a GI perspective. You go over that 450 and 600, you start to get some GI intolerance, which makes it a little difficult for the average patient to deal with. And for the more vulnerable patients or the ones with, gastritis and other issues, that's kind of a deal breaker for them. But it's also very helpful in some diabetic infections and can be useful as an anaerobic coverage in, say, diabetic foot infections and so on, which is a bit off topic for us today. Any other
A
questions?
question from online. For someone allergic to more than one antibiotic, are there many alternatives? For myself, I have been exposed to aminoglycosides, vancomycin, rosifin, zosyn, penicillin, and have had rashes, itching, and inflammation whenever I reconstitute them or interact with them to administer to my patients. So I don't have many alternatives, and I'm afraid of taking them. not knowing what to expect.
That one's a bit tricky. It really comes down to what organisms are you concerned about. So the alternatives depend on the coverage that you require. If there are things that are susceptible to alternative agents and you can try them, but it comes down to what infection are you dealing with, what are the likely organisms, what alternatives can I get for coverage. And that may mean that you have to also look at what type of allergic or hypersensitivity reaction you are getting and what is the basis for it, how severe is it. Is it just rash and itching? Is it flushing? You know, is it dizziness? Is it more an angioedematous type reaction? You have to look at that because then the grade of severity determines also how much avoidance potential or how important it is to stay away from the class of drugs altogether. But that's something you may have to maybe have a specific conversation about because that can be tricky. But in terms of administering and reconstituting, the recommendations usually would be to double glove and be careful about how you handle the powdered substances and any spills.
Okay, Doc. All right, we have a number of questions. We're gonna try and go through this rapid fire. One, where can skin patch test be done?
Skin patch testing is often done by the dermatologist. I know Dr. Fitzhenley would do it in his office. There is an allergist who comes to Jamaica periodically. I think a Dr. Crump, if I'm not mistaken, and he does do skin patch testing. So generally speaking, you would ask your dermatologist or you would go to an allergist. It's just that we don't have an allergist here, you know, every day of the year.
Good morning.
Morning.
All protocol observed. Thank you so much for these educative and impactful lectures that we had this morning. Coming here this morning is not a waste of time to me. Yeah, I'm really blessed. My questions, going back to home remedy, how often for a patient with sinusitis, how often can he or she have a steam inhalation? How often can it be done?
Okay.
Thank you.
No problem. So generally speaking, the menthol saline steam inhalation, which is what I usually recommend, is with menthol crystals, salt, depending on how hypertensive a patient may be, because you can do it without salt, and then also boiling water. So this can be done 3 times a day, 4 times a day, and it depends on how thick the mucus is and how persistent the blockage. I usually recommend that people try to do it for 15 to 20 minutes, 3 times a day for at least 5 to 7 days when they are having symptoms, but they also need to engage in alternative things. So maybe taking an antihistamine or an antihistamine mast cell stabilizer combination, using a nasal corticosteroid if indicated because of the frequency of their symptoms. And generally, people tend to do it with a little cup and a towel. This does not work. Okay, this just does not work. We need to cover with a sheet. You want something big because you want to form a steam cave where you're trapping a large volume of steam available for inhalation. So I usually recommend that people set up either on the floor on a cushion, at their table, have a large bowl or a small basin, put 1 single piece of menthol crystal, usually about a rice grain size, in the bowl or basin, plus or minus a teaspoon to a tablespoon of salt, and they boil up their kettle or their pot. They have their sheet ready and opened out. They pour in the boiling water, cover with a sheet, and start inhaling the steam. And most people want to take a damp wash rag with them for eye irritation or for wiping for other reasons, or tissue so that they can blow their nose. And it's important that that first breath can be very harsh. Don't use a whole bottle of menthol crystals. 1 piece is sufficient. Okay, maximum 2. And then what I usually say is if the first breath is intolerable, just stick your head out to the side and take a deep breath of regular air and go back, and usually the irritation passes.
T-
15 to 20 minutes, 3 times a day for 5 to 7 days.
Okay, thank you. So we have room for 2 more questions. We're going to take one in-house and then one online.
Okay.
Dr. Pete Robbins, you mentioned menthol, you mentioned, I think, saline nasal sprays. What can you say about steroids? Because patients often come to me asking for a steroid spray.
So you have different levels of symptom relief and control. So from an allergic rhinitis perspective, your controller is going to be your steroid nasal spray, because that is going to damp down the allergic response in the region, depending on the agent that you choose. Some are better than others. And it is going to reduce the frequency and severity of symptoms, because it is providing a broader based reduction in that allergic response. For some people, a mast cell stabilizer will be sufficient with their antihistamine. But when you have frequent symptoms or severe symptoms, or you have someone who typically cannot avoid their triggers, maybe they have people in their community who burn garbage every day, or there are other things that are constantly triggering them. Their work environment is a dusty environment. They deal with a lot of paper or AC, or they sleep under a fan because it's unbearably hot. Whatever the risk factor or trigger that they can't control, then a nasal spray with a steroid in it would be indicated, because that gives you much improved symptom relief and reduced frequency of attacks. When somebody is actively having an infection, that can be tricky, because at that time that may allow the infection to get out of hand if they are not on antibiotics and they actually have a significant infection. So you have to evaluate them carefully in the acute phase. But generally speaking, once you're on a steroid nasal spray for 5 to 7 days, you usually have a significant reduction in symptoms, and that reduced frequency and severity of drainage and mucus production and irritation and swelling of the airways means that your risk of infection moving forward is also significantly reduced. So it's an important measure for control. And depending on the agent you are using, many of them don't have a lot of systemic absorption. So your side effects to systemic circulation are usually fairly limited. And most of them are much more tolerable than they used to be. Some of them used to have alcohol in them, they've taken that out and so on. So there are a lot of good things about it. I would say one thing about it, in terms of usage, it's important where you point the device. So it's important to tilt it back and a little out. It's not good to stick it up like this or to point it in. The devices should be tilted back and out to be able to pass the turbinates and get up into the spaces that you are targeting. So that's also important.
Thank you so much. Final question.
Sure.
Could you repeat the antibiotics that you said does not penetrate surfactant?
Oh, ciprofloxacin is not good for anything to do with the lungs when you consider surfactant as a factor. So a lower respiratory tract infection, you would not choose ciprofloxacin as your quinolone if you're looking for quinolone. Not in preference. I mean, if that's all you have, you may use it, but it will have some reduced effectiveness, especially if there's a lot of alveolar issue, because that's where the surfactant is.
All right, everybody, give her a round of applause, please. Thank you so much, Doc. And for the questions that weren't answered, of course, we'll share them with Doc and see if we can get those answers and share by email later. We now have a video for you from Sandoz.
Sandoz is the global market leader in generic and biosimilar medicines. Whatever we do, we put the needs of patients first, making high-quality, cutting-edge medicines accessible to more patients, whenever and wherever they need them. and at prices they can afford.
As you can see by my watch, which is keeping time, we are absolutely on target. So right now, we're going to introduce our next guest speaker, and we'll invite the lovely Ashley to come and do the welcome. Please. Make her feel, come on. Thank you so much. She's nervous enough, so give her some support. Thank you so much.
Thank you so much, Nakia. Hello, everyone. It is a privilege and a pleasure to introduce to you our third speaker for today. She wears several hats, few being consultant ENT surgeon and head of the department at the Bustamante Hospital for Children, associate lecturer at the University of the West Indies, vice president of Jamaica Association of Otolaryngologists, head and neck surgeons. Our speaker goes beyond the scope of patient care by serving as a coordinator of the Animal Assisted Recovery Care Project launched March 2023 at the Bustamante Hospital. Her passion for her specialty made room for a plethora of achievements, conducting many scholarly activities and being instrumental in the publication of articles such as Instrumentation and Techniques of Examination of the Ear, Nose, and Throat and Sinus, and Infected Bronchial Cyst, completed by Retropharyngeal Abscess, Cervical Osteomyelitis, and Atlanta Axial Subluxation. Through our expertise, our speaker will share insights on the topic antibiotic use in acute sinusitis and otitis media infections in pediatric patients, an era with relevance. Get ready to be informed, intrigued, and inspired. Please join me in giving a warm welcome to our erudite speaker, Dr. Marcia James.
Morning, everyone. Thank you, Ashley. I mean, you really set me up intriguing and erudite. I'd like to thank SANDOZ, especially Christian and the team, for inviting me to be a part of the meeting today, and for all the persons who have come out in person and logged in online to listen to our presentations. So coming further down on the program, I realized that a lot of my information was already presented by Dr. Curtis. And then I saw a few of my tables in Dr. Pate Robinson's presentation. And then, you know, I'm always impressed by her, so big shoes to follow. So today I've been asked to speak on the antibiotic use in the pediatric patient for treating acute sinusitis and otitis media. Oh, this goes pretty fast. So my disclaimer that you'd have seen before at previous speakers, and the outline for my talk today will start with just recalling the basic anatomy of the ear and the paranasal sinuses, classifying acute otitis media and acute rhinosinusitis, recognizing some of the clinical features of these conditions, and discussing the role of antibiotics in the management of these conditions. And also to have a little look at pediatric patients who would need surgical intervention. After all, I'm a surgeon. So what's the rationale of combining these two topics today? So there's an association between the occurrence of both acute otitis media and acute bacterial rhinosinusitis. And this is because the membranes lining the nose are continuous with the mucosa lining the nasopharynx, the sinuses, and the middle ear. So a lot of the microbiology is pretty similar. And these are two of the most common conditions for prescribing antibiotics in the pediatric population. And what we notice as well is that if these are occurring together, there's an increased risk of treatment failure without the use of antibiotic therapy. So if you recall about the paranasal sinuses, they are paired structures. The maxillary sinus and the ethmoid sinuses are present at birth and can be radiologically imaged at that time. At about 5 years, you'll see the sphenoid sinus on your radiological images, and then these sinuses continue to grow until they achieve their
maximum size between 12 to 14, with the frontal sinuses starting to pneumatize at about age 6 and becoming pretty prominent on x-rays about age 12. And then by about age 18 to 20, the sinuses would have achieved their final adult size. With regards to the ear is divided into 3 parts. You have the outer, the middle, and the inner ear. And otitis media deals with the middle ear cavity, which contains the ossicles. It's bounded laterally by the tympanic membrane and communicates with the inner ear medially. The eustachian tube is an anterior-inferior relation, and as you can see from this diagram, you can see how the mucosa can be continuous from the middle ear into the nasopharynx. And in children, the eustachian tube is more horizontal, and this allows the retrograde passage of organisms, predisposing them to infections within the ear. So let's look a little bit more at some of the definitions. Again, these were said before, so this is just a recap, as my daughter pointed out I would be doing. So based on the AAP guidelines that were revised in 2013 from the ones that were sent out in 2004, there are 3 components. So you have persistent illness, which is defined by nasal discharge of any quality or a daytime cough, or both lasting more than 10 days without improvement. For the worsening course, you have onset of the nasal discharge or the cough or fever, and this is after a period of improvement. And we have been seeing quite a few patients presenting with this. They're doing well with or without antibiotic therapy, and then there is what some people refer to as a relapse, but they represent with worsening symptoms. Then there's a severe onset where these patients present with high-grade fever, purulent nasal discharge, and usually for more than 3 days, consecutive days. There's also the concept of recurrent acute bacterial rhinosinusitis, and this occurs when there are episodes of bacterial infection within the sinuses fewer than 30 days, and they're usually separated by at least 10 days of asymptomatic intervals. Or another criteria that is used is at least 4 episodes in a calendar year. So the important thing with recurrence is that they must have resolution in between the episodes. So acute bacterial rhinosinusitis complicates about 7 to 10% of upper respiratory tract infections. Average age of presentation in the pediatric population is between 1 to 2 years, and girls are more frequently affected. Complicated sinusitis is often more commonly seen in adolescents and more so young males, but we have been seeing an increased prevalence in our younger age groups. In the US, about 82% of children are prescribed antibiotics for acute sinusitis. So sorry. Right, so as Dr. Pate Robinson mentioned, the etiopathogenesis of acute bacterial rhinosinusitis is a combination of mechanical obstruction of the drainage osteo. There is also impaired function of the cilia, so they're unable to move the mucus along. There's mucosal thickening and oversecretion of thickened mucus, making this a nice media for bacteria. So there are some other things that we have to consider. So I know Dr. Robinson had mentioned that, you know, we use a lot of complementary adjuvant therapy outside of antibiotics, but we also need to remember that there are some aspects or some patients in our population who may be at a disadvantage because of local or systemic issues that can predispose them to severe infection. So we have our allergic and our non-allergic rhinitis patients, but allergic rhinitis does increase the incidence of rhinosinusitis and bacterial rhinosinusitis as well. As we saw before, it complicates upper respiratory tract infections. Patients with anatomical abnormalities within the nose and sinuses are also at an increased risk of infection because of impairment of the drainage patterns. Patients with nasal polyposis, patients with sinonasal tumors, and patients with atopy also have an increased incidence of rhinosinusitis. Smoke exposure that impairs ciliary motility has also been a big risk factor. And that is something that we see often, especially most recently with this Riverton and dump. With it, we see an increase with the smoke exposure. And patients who have had previous surgery that required nasal intubation. So there would have been some trauma to the nasal mucosa. So systemic factors, as was mentioned before, any patient with immunodeficiency, again, we must also remember our patients with sickle cell disease within our population, patients with cystic fibrosis, any ciliary disorders, and gastroesophageal reflux has also emerged as one of the risk factors for patients who develop recurrent rhinosinusitis. So according to the American Academy of Otolaryngology, Head and Neck Surgery, the diagnosis of acute rhinosinusitis can be made if there's up to 4 weeks of purulent nasal discharge, and this can be cloudy or colored, and it can be anterior, posterior, both. There should be nasal obstruction, which the patient may complain of, which may include congestion as well as stuffiness, and facial pain, pressure, or fullness in the anterior face, periorbital region, and headaches, which may be localized or diffuse. So what are we looking for in our children? A lot of children present with upper respiratory tract infections that are usually viral. Again, these can be complicated by acute bacterial rhinosinusitis. So you're looking for the nasal discharge. If it's not clear, if it has become cloudy, then you should be concerned. This daytime cough, sometimes nocturnal cough as well. They may have halitosis and non-specific symptoms, including fatigue and decreased appetite. When you examine the patients, you will see erythema and swelling of the nasal turbinates. This can also be non-specific because you will see this in allergic rhinitis and in patients with an upper respiratory tract infection as well. In children, percussing the sinuses is not very useful, and transillumination is difficult and unreliable in children. So usually this is not done. One of the adjustments to the guidelines was imaging. So if you suspect that a patient has acute bacterial rhinosinusitis, as Dr. Price said earlier, is usually a clinical diagnosis. What they have seen is that when you image the patients, you will see changes within the sinuses and within the nasopharynx. But these can be non-specific, and these same changes can appear in a patient with uncomplicated upper respiratory tract infection. So it's not usually very useful for that. But if you suspect that a patient has complicated sinusitis, then definitely that patient needs to be imaged immediately. And this is usually a CT with contrast. So a lot of times we get patients, they have a non-contrast CT, which is sometimes not very helpful, and then we have to re-image the patients. MRI with contrast as well is useful for the patients with intracranial complications. So what are the complications that we're talking about? So orbital complications are usually the most common, and or intracranial complications including meningitis, subdural collections, brain abscesses, osteomyelitis. We have had a few patients with Pott's tumor, yes, pediatric patients, and cavernous sinus thrombosis. This is not very common. And few patients do report asthma exacerbation. So the orbital complications, what are you looking for? So you're looking for periorbital swelling. So you can use the Chandler's classification that you would have learned from medical school. So in group 1, you have preseptal cellulitis. Patients with orbital and intracranial complications should be managed inpatient with IV antibiotics. So you're looking for the preseptal cellulitis or orbital cellulitis, which has the preseptal cellulitis that has extended. Patients with subperiosteal abscesses, that's group 3, orbital abscesses and cavernous sinus thrombosis require multidisciplinary management or may require surgical intervention. The most common pathogens that you'll see are pretty much the same ones that you see in acute otitis media, and these are 3 top ENT pathogens, which are your strep pneumoniae, your Moraxella catarrhalis, and your Haemophilus influenza. Rarely you'll see Staph aureus in acute sinusitis, and we do see some anaerobes, and so we use a combo therapy. So you'd have seen this slide, I think, before in Dr. Robinson's presentation. So the recommendation from the American Academy of Pediatrics is that if the patient presents with uncomplicated acute bacterial rhinosinusitis with no comorbidity, meaning no concomitant otitis media, pneumonia, adenitis, or strep pharyngitis, then you can do 3 days of observation with a SNAP prescription that Dr. Price had spoken about, which basically you give the patient a prescription, you follow up in 3 days if it's a reliable patient or you have some way of communicating with the patient, and if the symptoms worsen, then they fill the prescription and start the antibiotics. If the patient has worsening or severe symptoms, then antibiotic therapy is indicated immediately. Complicated acute bacterial rhinosinusitis, antibiotic therapy, and this is usually inpatient. And for patients with coexisting illnesses, we recommend that you begin antibiotic therapy. For these subsets of patients, neonates, patients younger than 1, I'd say even patients younger than 2, patients with any sinus abnormalities, asthmatic patients, patients with immunodeficiencies, cystic fibrosis, previous sinus surgery, or gastroesophageal reflux disease, I would begin immediate antibiotic therapy for patients who meet the criteria for acute bacterial sinusitis. So what are we giving? So the recommendation is amoxicillin at a minimum of 45 milligrams per kilogram. I see a lot of pediatricians and some general practitioners working it out at 30 milligrams per kilogram. And the patients do come, they do complain, you know, their kids not getting better. We look at the dosing and we realize that it's below the 45 milligrams per kilogram. You can also go up to 80 to 90 milligrams per kilogram in worsening or severe infection. And because at Bustamante, we're a tertiary referral center, they would have been treated previously by other physicians. We normally just begin at amoxiclav. There's also the option of using a cephalosporin. If the patient is less than 2 and has had previous antibiotics in the last 4 to 6 weeks, then we begin with amoxiclav. We forego the amoxicillin, and clindamycin is also an option here as well. If it's mild disease or moderate disease and the patient has received antibiotics in the last 4 weeks, you can try high dose amoxicillin or amoxiclav, and if the patient is allergic, one of the cephalosporins. We spoke a little bit about levofloxacin, restricted in the pediatric age group, but I've seen some response in the older pediatric patient, because remember, pediatrics is from neonate to 18 years, according to WHO definition, but it works pretty well in the adult patients as well, especially for those who have had a previous trial of amoxiclav. Patients with moderate to severe disease or less than 2 years old, we suggest that you start with high dose amoxiclav, which is 80 to 90 milligrams per kilogram. Or there are some patients who won't tolerate oral antibiotics or the entire course. You can give them ceftriaxone 50 milligrams per kilogram IV or IM for 3 days. And clindamycin is also another option for these patients. Note that for acute bacterial rhinosinusitis, azithromycin and Bactrim are not recommended. So I know that azithromycin is easy to prescribe. You think that there will be patient compliance, but usually they'll come back and you will have to start the amoxiclav. So if your diagnosis is acute bacterial rhinosinusitis, please do not prescribe azithromycin. Role of adjuvant therapy is very important. Again, there are some patients who will have a viral acute rhinosinusitis. Intranasal steroids help to reduce the inflammation. Intranasal steroids do not result in decongestion quickly. It's with use over time. Remember, it's a low dose steroid that is being used, so it's incremental use that you will see effects. So When you prescribe your intranasal steroids, you have to manage the expectations of the patients because they will say, oh, but it's not working, it's not helping. But it's not something that will give you an immediate effect. Usually you get that from your decongestants. We recommend saline lavages and rinse, not just saline sprays. So a lot of time they'll buy, I think there's one called Comfy Nose that everybody loves, adults and children, and they'll just, give 2-3 puffs and they're very happy. No, you actually need to wash out those sinuses. Antihistamines are very useful in your patients with allergic rhinitis and patients with gastroesophageal reflux. Anti-reflux medications are indicated. And of course, lifestyle modification. So you need to identify your triggers and reduce the exposure as best as you can. All right, so that's it for acute bacterial rhinosinusitis. I think all questions are reserved till the end. So I'm going to move on now to acute otitis media. So how do we define acute otitis media? I think this was said before, but we'll just recap. It's usually a 3-part definition. So it's usually acute onset of symptoms. There should be a middle ear effusion present and confirmed by pneumatic otoscopy or tympanometry. How many persons do pneumatic otoscopy? Okay, moving along. Signs of acute middle ear inflammation. So this could range from moderate to severe bulging of the tympanic membrane, mild bulging with the patient complaining of otalgia and some hyperemia of the tympanic membrane, and especially if there's new onset otorrhea, which would mean that there's some perforation. Recurrent acute otitis media occurs when there are 3 or more well-documented and separate episodes of acute otitis media in the preceding 6 months, or 4 or more episodes in the preceding 12 months, with at least 1 episode occurring in the past 6 months. So we do get a lot of referrals, and we get persistent otitis media, or they're unresolved, or recurrent acute otitis media, but recurrence occurs with complete resolution between episodes. So what are you looking for? So as you can see, there's bulging of the tympanic membrane, and the presence of the middle ear effusion gives you that donut appearance. So acute otitis media actually complicates 30% of upper respiratory tract infection, according to the studies that I reviewed recently, with a peak incidence between 6 to 18 months. So you'll see acute otitis media more often than you'd see acute bacterial rhinosinusitis. And you'll find that patients who have an early age of the first infection tend to have recurrent otitis media. 90% of children will experience an episode before school age. And again, because some of these patients are placed in daycare. So the pathogenesis is also multifactorial. It has a lot to do with eustachian tube dysfunction. The eustachian tube is not as well formed and defined as in the adult patients, and there's a risk of aspiration of pathogens from the nasopharynx, as well as adenoidal biofilms and vegetation that can cause recurrent infections. Unfortunately, in the pediatric age group, the presentation for the patients can be very non-specific. So they may present with nausea or vomiting, they may present with irritability, fever, lethargy. Some patients may complain of otalgia if they're verbal, non-verbal, they may be tugging or rubbing, but usually there's rapid onset of the symptoms and usually a previous history of a viral infection. And it's important for you to ask about the past medical history and social history to see if these patients have any of the predisposing risk factors. So when you do your pneumatic otoscopy, you're looking for color, position, and mobility. So the pneumatic otoscopy, you basically be trying to see the mobility of the tympanic membrane, and it is reduced in patients with severe acute otitis media. So we were seeing quite a few patients with complicated sinusitis, not so much the acute otitis media, but now we're seeing more patients with complications. So one of the things you need to look out for is complications within the in the ear, within the temporal bone itself. So you're looking at abnormalities within the middle ear. So if there's a perforation, patient has mastoiditis, if the patient has chronic suppurative otitis media, the presence of a cholesteatoma, if you notice any facial nerve palsy, even if you think it's Bell's palsy, I would advise you to refer the patient to ENT for further evaluation. Patients may also present with hearing loss and labyrinthitis. In our pediatric patients, we do see quite a few intracranial complications, so usually subdural abscesses as well as some extradural abscesses, brain abscesses, and we have seen patients with petrous apicitis or patients who presented with meningitis. Rarely have we seen any patients with bacterial sepsis. So again, the same pathogens. Group A streptococcus in about 2 to 3% of patients have been reported, as well as staphylococcus aureus and pseudomonas has been found in some neonates. So why are we using antimicrobials, even though most cases of acute otitis media are viral? What they've found is that if patients have worsening symptoms or severe disease, the road to recovery is quicker, shorter duration of the illnesses, and patients with concomitant illnesses recover faster. You also want to prevent complications that are associated with increased morbidity, and you also have to look at the likely pathogens as well as your local susceptibility patterns to determine which antibiotics will be most effective in treating your patients. So Dr. Pete Robinson actually showed this table before. I just broke it into two. And what are the recommendations? So below 2 years, antibiotic therapy is usually indicated. If the patient has a unilateral otitis media without otorrhea and you have a highly motivated patient and a good communication system like what Dr. Price has, where he's WhatsApping the patients and messaging, I won't promise anybody I'm doing that because patients love to WhatsApp at 2 o'clock in the morning, at 4. But if you have a very good communication system, then you can do that 3-day period of observation. For patients with otorrhea, which would mean that therapy is indicated. If they have concomitant acute bacterial rhinosinusitis, antibiotic therapy. So for immediate antimicrobial use, less than 6 months, as was said before, if the patient looks ill or toxic, and you can know, because children are very honest. If they're sick, you know that they're sick. If you suspect that they have a concomitant illness, even if it's a lower respiratory tract infection, you should initiate antimicrobial therapy. A perforation, as we said before, if the patient complains of hearing loss, patients with anatomical abnormalities, and of course, patients with complicated acute otitis media need to be managed as inpatients. So what are we recommending? So when we say delayed, this is the 3-day observation period. Amoxicillin, high dose, 80 to 90 milligrams per kilogram, so not the 30 milligrams per kilogram, or amoxiclav, especially for patients who have had previous antibiotic therapy. Alternatively, you can give cefuroxime or another cephalosporin, or you can do the IV-IM ceftriaxone for 1 day or extend to 3 days if the patient is not responding. And I've done that with some patients, especially patients who are on the spectrum who are very particular about their oral intake and textures, and I've gotten some good resolution and effect. So if the patient failed an initial antibiotic treatment, if you did your 45 milligrams per kilogram, you can then, after 72 hours, switch to amoxiclav 80 to 90, or they suggest going all the way to 90 milligrams per kilogram BD for 10 days, or again, ceftriaxone therapy, or you can use clindamycin at 30 to 40 milligrams per kilogram. And you can combine that with a 3rd-generation cephalosporin. So the standard course should be 10 days for children under 2 and children with severe disease. They have mentioned the 5 to 7 day course for children, but usually 6 years of age and older with a more robust immune system and with mild to moderate disease. So patients with severe disease, the 5 to 7 day course is usually not as effective. One of the things that we find that when we're treating the patients with otitis media, yes, we prescribe the antibiotic, but we forget about the analgesia. Ear pain is a very serious pain. It is very painful, and analgesia is very important. So as Dr. Pate Robinson had said, there are some patients, whether you give them antibiotic or not, they will improve. But those patients will require some analgesia. So for patients, you know, we are dengue endemic, so you can use paracetamol or Baralgin. For patients with severe inflammation, I find cataplam to be more effective. You can also try to use some topical, but that only works in about 30% of patients and usually not as effective. The AAP also recommend encouraging patients to get the pneumococcal conjugate vaccine, because what they're found with this vaccine, the prevalence of acute otitis media has fallen, not so much for acute bacterial rhinosinusitis, but definitely for otitis media. We don't, the tympanocentesis is not something that I personally recommend, but it's in the guidelines. And there's also talk about using an immunomodulator to boost the immune system, OM85. And there are a few studies out, especially since COVID, which have shown some promise. I don't know if that's available here. Oops, sorry. Oh, this goes a little fast. All right, so they also recommend the use of tympanostomy tubes or grommets for patients with recurrent acute otitis media. So remember, these are patients with 3 episodes in 6 months or 4 episodes within a calendar year. For the ENT surgeons, we may offer tympanostomy tubes for patients with recurrent acute otitis media. And usually, if it is that when we evaluate the patients, there is a persistent effusion at that time. We often combine it as well with adenoidectomy because of the adenoidal vegetation and biofilms that can cause recurrent infections. So if you have patients who are not responding to antibiotic therapy, you can refer for this treatment. Again, we need to be good antibiotic stewards and to reduce resistance. There are no new antibiotics really being developed, and we really have to take care with the ones that we have now. So some of the risk factors for antibiotic resistance, so attendance at daycare early. I know this is difficult, especially for working parents, but if we're more vigilant with how we manage the patients at daycare to reduce the spread of infection, this may help. Patients with their first infection less than 2 years, these patients are going to end up getting more antibiotic therapy and therefore have an increased incidence of antibiotic resistance. Patients with pathological biofilms, they are usually not susceptible to antibiotics. So we keep treating them with no effect. If you think that the patient may have biofilms within the nasopharynx, then refer the patient. Surgical intervention might actually be helpful and useful for these patients. And please review the patient's antibiotic histories. The parents now are very vigilant. Some of them have logs. They have the pictures of the antibiotics. They can tell you which ones they were given by whom. So that's a part of your assessment and decision-making process for which antibiotic you will initiate therapy with when you see them. And also remember to give the proper duration of treatment. So what will happen is that you'll have patients who are partially treated, they'll respond, seem to be better, and then they represent. So ensure that you're treating them for the adequate duration of time. And we do not advocate the use of prophylactic antibiotics, sorry. A lot of parents will come and say, oh, doc, can you just give me some antibiotics? Oh, doc, I'm going to Miami. Just give me a prescription. I just want to carry it just in case. No. We do not support that. All right, so I'm going to go on now to see how well you have been listening, and I'm going to present a few patients, and you can tell me what you think and how you think these patients should have been managed. So we got a 70-year-old male who was a known asthmatic. There was a history of facial trauma 12 days prior to presentation to a regional hospital where his Mother reported fever, neck pain, headache, and swelling to the angle of the mandible, which is where the facial trauma was initiated. She reported that he had seizures lasting for over an hour and ptosis of the left eye. On examination, there was a warm tender swelling about 7.5 by 1 centimeter at the left angle of the mandible, and Brodinski's sign was positive, Kernick's was negative. So what you guys thinking so far? I can't hear. Anybody? So you're thinking possibly meningitis? Yes. All right. Yes. Okay. What do you think about the history of the facial trauma? Think that was contributory? Okay. Very good. What about being asthmatic?
Okay, all right, so we can deduce 3 things thus far. Number 1, meningitis, because of the seizures. All right, there's fever, so there's an infectious process going on. Now, the facial trauma could have resulted from one thing. You could have had some breakage or communication between structures causing oral commensals to go into the sinuses. That lead to a sinus infection, which can in fact lead to meningitis.
Where you work, Doc? Yes, man. Thinking,
Yes.
Yes, man, you're thinking. All right, so they entertained the diagnosis of meningitis. A lumbar puncture was done. CSF was clear. Glucose was 3.3, and WBC was 23.3. There's supposed to be a dot there. And the CSF culture grew Enterobacter with a sensitivity to ampicillin, ceftazidime, ciprofloxacin, ceftriaxone. Labs, HB was 11.4, and white cell was 21.85 with a neutrophilia, ESR and CRP were both elevated. And they requested a CT scan, of course, because of the seizures. And Doc, you're on the right track. So the patient actually had a complicated sinusitis, as you can see. The ethmoid sinuses and maxillary sinus are full. Oops, I'm so sorry. And if you look on the image to the right of the screen that you're facing, you see as well that there is an intracranial collection as well. The patient had a subdural abscess. So the patient was managed with augmentin, metronidazole, ceftazidime, they added meronym and clindamycin, and the neurosurgeons took the patient to theater, did a burr hole aspiration, and ENT added intranasal steroids, antihistamine, mannitol and phenobarbital added initially and then discontinued. The patient spent 43 days in hospital, had a repeat scan, and as you can see, the sinuses improved without surgical intervention. So there was good response to the IV antibiotic therapy. All right, so on to case 2. So this is a 3-year-old male with sickle cell disease, HBSS phenotype, and has a history of recurrent otitis media times 3 episodes in the past 6 months. He presented to the ENT clinic with a purulent left ear discharge, fever, otalgia, and anorexia. On examination, he had a purulent ear discharge. We were unable to partially visualize the tympanic membrane, and he was prescribed oral cefuroxime because he had gotten amoxiclav previously. He was given topical ciprofloxacin and dexamethasone, which is Quidex, Cataflam for the inflammation, as well as Panadol, with a 2-week review. On review, he still had otorrhea and what appeared to be an oral polyp. So oral suctioning was done and the meds were re-prescribed. He then presented to a regional hospital with a history of fever, being unresponsive and vomiting times 2. On admission to that hospital, he was given meningitic doses of roquefin, flagyl, and dexamethasone. A CT brain was ordered because of the history of being unresponsive and vomiting. They were thinking something intracranial, and what they found was a collection at the petrous apex, as well as a collection intracranially with dural enhancement, opacification of the mastoid ear cells. Patient also had a communicating hydrocephalus. A bit difficult to see, but what you'd have seen is opacification of the mastoid ear cells as well as the middle ear cavity. So the patient had some dysmorphic features, but the GCS on evaluation was 11 out of 15. He had positive Brzezinski and Koenig sign. Pupils were equal and reactive to light. He had the persistent left otorium, but his cranial nerve exam was normal. And he was commenced on meronem, amikacin, and clindamycin when he was transferred to Bustamante. So he was accepted both by ENT and neurosurgery. They ordered a carotid Doppler to rule out any thrombotic events, and an MRI brain and internal auditory IAM, so basically looking at internal auditory meatus, as well as a chest X-ray because there was a history of him having acute chest. So he was managed primarily by neurosurgery. They placed a EVD drain for the hydrocephalus. The CSF cultures were no growth, and they discontinued cataflam and mannitol as he improved clinically. We continued with IV antibiotic therapy and oral suctioning, and the patient continues to do well. So this is a patient who actually presented with petrous apicitis. Is there anything you'd have done differently for this patient?
If anyone would like to comment, the mic is right here. Don't all comment at once.
They're thinking. Dr. Koff. Well, I think one of the things that stood out is that the patient has HBSS. So this is a patient who is immunocompromised. I would have wanted that this patient be referred earlier and probably managed as an inpatient. All right. And then our last case was a 9-year-old male who was referred again with recurrent ear infections for 2 years. And then he presented to the clinic with a 1-month history of right ear pain and discharge. He was noted to have a large polyp that was occupying most of the external auditory canal. And he was booked for examination under anesthesia and polypectomy. We also ordered a CT and MRI of the temporal bone to assess the extent of the polyp, because sometimes it's difficult to assess where the polyp is originating from or how extensive it is. So you can't just go in and yank off a piece. You might be pulling out important structures. So this patient was treated initially with oral amoxiclav and topical ear drops, so ciprofloxacin and dexamethasone again. When he wasn't responding, he was switched to cefuroxime. On admission, he was treated with IV rocaphine and flagyl. His ear swab grew E. coli, and his labs were fairly normal and stable throughout. When we got the CT temporal bone and the MRI, there is extensive disease destroying the middle ear. There are no ossicles identified. It extended all the way to the otic capsule. So this was more than just our regular granulation inflammatory polyp. He was sent for hearing tests. Anybody can read this? Anybody remember how to read this? Who wants to tell us what's happening in this hearing test? Nobody? No? Nobody at all? Want to hazard a guess? No, guys, you're like the medical students. I have to call on somebody. Where's Dr. Price? He left. All right, so the patient had a conductive hearing loss, moderate conductive hearing loss on the pure tone audiometry, and to the right of the screen is the tympanometry. So type A, normal in the left ear, and a low peak in the right ear. So these are some images from the mastoidectomy showing extensive disease. No ossicles were identified, and but there is no involvement of the inner ear. And the patient is continuing treatment with topical ciprofloxacin and dexamethasone and doing well. So another thing I wanted to look at was our antibiotic prescribing patterns. So this helps us to, practice antibiotic stewardship, to identify susceptibility patterns, and to monitor adherence to guidelines. Are we actually following the guidelines that have, persons have come together, multidisciplinary approach to guide us in our management. Of course, there'll be nuances based on patient factors as well as local factors, because there are some agents that are not available to us. We don't have that access to healthcare. Affordability of healthcare varies. And also to be aware of the WHO aware list. How many persons know about the WHO aware list? Hands up if you know about it. Not Dr. Pate Robinson, of course, not her. Anybody else? Nobody? Guys, really? Okay. All right, so honestly, it's during my reading, just this week, that I became aware of it. So confession is good for the soul. So there's a list, actually, of what we call A's for access, AA is for watch, and R is for reserve. So we should be using mainly the drugs that are listed on the access, limit the watch because of the risk of increased susceptibility and resistance when the access drugs are not available, and then of course the reserve for severe cases. So I looked a little bit at what the antibiotics being dispensed at the NHF pharmacy at Bustamante. The system was very complex. It was not very user-friendly. Miss Palmer Dawkins, God bless her, sat down and worked out the milliliters of the antibiotic that was dispensed and then worked it out by bottles. And this is what we saw. So most of the outpatient prescriptions was for amoxiclav. So there are two preparations. One is the 228 and then the 475. So mainly the 228 was dispensed with a total of about 10,000 bottles being dispensed between January to March 2024. I was not able to disaggregate by specialty or anything because the system doesn't allow you to see which, what we'd look at is which team would be prescribing these. But what we are seeing is that amoxiclav is definitely heavily used, less for amoxicillin on its own. And cefuroxime, surprisingly, there were probably about 150 bottles that were dispensed during that time. Not sure if it was due to availability. And as you can see, 3,600 bottles of azithromycin were dispensed. And azithromycin is actually on the watch list. But again, everybody likes it because, increased patient compliance, short duration, but it's not indicated for acute otitis media or acute bacterial rhinosinusitis. For the IV preparations, amoxicillin, there were about 2,500 bottles dispensed, and that was mainly for the nursery because, again, being a tertiary referral center, we would be going to the next tier in terms of antibiotic prescribing. And again, amoxiclav was the most commonly prescribed or dispensed IV medication. Cefuroxime was about 490 bottles, ceftriaxone about 1,600 and something bottles, and then ceftazidime was also widely used. And this usage was seen not much by ENT, but a lot by neuro and orthopedics. So basically, what I want you guys to remember is there's to be really stringent with your antibiotic use, because this will help to reduce treatment failure and also to prevent or reduce antibiotic resistance development. You need to recognize the complications. So I'd rather see the patients early rather than late so they don't have to spend 43 days in hospital. And adjuvant therapy and lifestyle modifications are very important. Just as Doc said, it's not all about giving antibiotics and pharmacotherapy. It's important to educate the patients, spend some time with them, telling them about the triggers, things to avoid, what to look out for, how they can just basically improve and live a healthy lifestyle. And just to remember when to refer the patients for ENTs. So you guys have been doing a really good job, but there are some patients who are a little trickier. And you can also call us if you want some advice, if you're not sure. The clinics are at Bustamante on Mondays and Wednesdays. You can reach out to any one of us and if you want to have a discussion, all right? But if you're following the guidelines, then your patient should do well. I just want to acknowledge Ms. Palmer Dawkins for sitting down with me and working out all of that. And of course, my awesome team at Bustamante, they helped me with putting the presentation together, patient summaries, and of course, the case.
Thank you, Dr. James. Excellent presentation as is expected and aptly received. So for persons who want to ask questions, we have a mic in the middle. For those who are closer to that mic, I can also come around. We'll take a few questions online as well. So we will have the question and answer starting now. Dr. Barnes?
Thank you very much. I think Doc had mentioned it before about this drug called cefixime.
Yes.
I think she had said that it's not, but it's here. It's here in the form of, I believe it's Denvar. Right.
Oh.
Yes, it is. What is its role in the treatment of acute otitis media? I realize
that it wasn't mentioned.
That it wasn't mentioned.
Right. Well, in looking at the guidelines, I did not see it as being one of the recommended agents, but I think that it's something that you can consider, especially if your patients are not responding to your initial treatment. I myself have not used it for any of my patients. And honestly, with the cefuroxime, the patients do complain of the taste and that the children don't tolerate it well. So I've not used a lot of cephalosporins, to be honest.
Okay, thanks.
All right, thank you. Dr. P. Robinson?
Her mic isn't on.
Hello? Oh, there we go. I'm so sorry. So just wanted to comment on the cefixime. So based on the spectrum of activity, where I usually place it is more for an oral step down from a third generation, mostly ceftrax, so not so much ceftazidime, because it's a little more on the, it's a little broad, similar to ceftriaxone, and decent bioavailability. So it's a good oral step down for something like that. Perhaps a little better coverage as a oral choice if you want that broader coverage than maybe your cefuroxime might give you, as the second generation cephalosporins tend to be a little narrower with some gram-positive and some gram-negative coverage, and the third generations tend to have more gram-negative coverage, less gram-positive coverage. So it really depends on what you're looking at and which patient, but more often perhaps as a step down after starting IV.
Thank you, Doc.
Yes, very good presentation, but I just want a little clarity. Someone with acute bacterial sinusitis with middle ear infection, you mentioned high dose amoxicillin. How often would you give that? Twice a day, like amoxiclav, or three times a day?
So 80 to 90 milligrams per kilogram in two divided doses, and a minimum of 10 days.
Thank you.
All right, thank you. We have another.
Well, the recommendation does say amoxicillin at 80 to 90, but honestly, I tend to go to the amoxiclav. For the TDS, for the amoxicillin. So Doc is saying amoxicillin, if you're going to do it, it's in 3 divided doses. If it's amoxiclav, then it's BD.
All right, we have another question here, Doc.
Thank you, Doctor, for this wonderful presentation. My question goes thus: what is the stake of immunization in preventing these acute otitis media? Thank you.
Well, as Dr. Price would have mentioned, as well as Dr. Pate Robinson, the use of the pneumococcal conjugate vaccine has shown some reduction in the incidence and prevalence of acute otitis media. We don't see as much reduction in acute bacterial rhinosinusitis, but we definitely do encourage that they get this pneumococcal vaccine. And there's also some advocacy
Mic check 1, 2. Hey, everybody. Yes, so as I said, you might see a frozen screen. You're not hearing audio except for my voice just now. We're working on it.
Absolutely no.
All right, thank you so much. So the questions online. First, is there still any concern for combining Cidal and static medication, say augmentin and doxycycline? If antihistamines thicken mucus, could it negatively affect therapy?
Depending on how you manage the patient. And one of the things we advocate is this saline badges. This
Mhm.
helps to keep the air moist. But
Mhm.
for patients, we recommend nebulizing normal saline. So if they're asthmatic and they have an they can use normal saline nebs as well to help to loosen secretions and address the first part of the question. Can you repeat? I'm not sure.
The first part of the question is there any concerns for combining both?
I will defer. I'm a surgeon.
For instance, augmentin and doxycycline. No? All right.
Hello? Oh, right. Sorry. So just to say that the combination of a bacteriostatic and a bactericidal doesn't really matter if they're providing the appropriate coverage. It's just that when you have very severe infections, you have deep-seated infections, or you have other challenges that reduce your chance of a good outcome, you would want to go for a bactericidal agent as opposed to bacteriostatic. But when combinations are required, as long as the mechanism of action is not competitive, then you can combine safely. So it should not affect that regardless of how thick the mucus is, and that's really a more supportive care management challenge.
Thank you, Doc.
Thank you very much. The next question. In my 2 decades of the practice of medicine, anecdotally, I have seen a very marked increase in treatment for presentations consistent with recurrent rhinosinusitis. Has this been seen in epidemiological studies? What are your takes on this observation, apparent or data validated?
So again, unfortunately, especially for the pediatric population, there not a lot in the literature to review and not a lot of recent literature as well. So a lot of what we do is anecdotal and based on our experience in practice. But yes, definitely, I think some of it has to do with the environmental changes, so global warming, just changes within our environments, including urbanization. And I think definitely since the COVID-19 pandemic, I've seen some increases in especially the complicated sinusitis, and we continue to see that incidence increasing.
Thank you so much. The next question is, can you discuss the use of amoxiclav ES suspension, 600 milligram by 5 milliliter?
Okay, so the amoxiclav ES, I'm not allowed to say the A word. But the C word doesn't have any ES that I know of, but it reduces the volume, and so it increases compliance. So you can get that 80 to 90 milligrams per kilogram, and also the clavulanic proportion is less, so the side effects, right, Doc, are less in terms of GI upset. So that preparation works well if you have to do the 80 to 90 milligrams per kilogram.
Yes, okay. So just a quick plug, shameless advertisement. So we do have the ES coming soon to a doctor, to our office, and a pharmacy near you. So look out for the C word. Yes.
Thank you so much. I think the final question is, what is the role of airdrops, if any, in the treatment of otitis media?
Right. So again, for the use of topical antibiotics, it would be if they have otorrhea. So if there's a perforation. There are some preparations that do have like a local anesthetic that can sometimes help a little bit with pain, but not very useful for most patients. Maybe 30% of patients may benefit from it. Yes, doc.
Just to, in addition to what he was saying, so
Yes.
you would both use the topical as well as the oral.
Yes,
in
you
that
can.
case?
Yes, you
Okay.
can combine them if they have otorrhea. Yes.
Okay, so we'll take 2 more questions. We have time for just 2 more. That's the last one? Last one? Okay.
Doc, I hope it's a comment you're making and not okay.
Just a comment on a previous question regarding the pneumococcal vaccines.
Yes.
So the primary utility of the pneumococcal vaccines is to reduce invasive pneumococcal disease. In the past, before we had the vaccines and the polysaccharide was the first available, there was a great deal of morbidity and mortality, especially in the pediatric population, associated with invasive pneumococcal disease. So you'd get bacteremia, you'd get meningitis, you'd get complications, and patients would do poorly, and the rates were very high. Once we had the polysaccharide vaccine, because it covered a large variety of serovars, and it reduced invasive pneumococcal disease from the more significant strains that caused it. And so it reduced the frequency of those severe cases. But then we saw an increase in invasive disease from certain other serotypes that were previously not a significant concern. So they expanded the coverage for the polysaccharide vaccine to again target these newly raising their heads versions. And the challenge then became the polysaccharide vaccine, because it's a sugar-coated target, it's not an effective vaccine, or I shouldn't say it's not effective, it's of reduced effectiveness compared to something targeting proteins. And that's why the conjugate vaccine became a big deal, because then you combined a protein target to the polysaccharide target, so it made your immune system recognize it better. And so the polysaccharide performs okay, the conjugate performs better, but the polysaccharide vaccine still has more coverage because of more strains being covered. So for people with increased risk of invasive disease from pneumococcus, then you would want both, and you'd get the conjugate first.
Okay. Thank you so much for that, Doc.
For Dr. Pate. Just a quick and last.
You should be answering this question. I hope you're not asking me a question.
No,
you know.
no, I'm actually taking from his slide and throwing back to Dr. Pate Robinson. Just to comment on the OM85 that you put on the slide.
Yes.
Yeah. So if you could make a comment on
Yes,
that.
yes, I'm interested as well. Thank you, Kof.
Hello? Okay. So I actually don't really have much of a comment on that at this point in time. I must confess it's not available here, not likely to be available here in a good while. There are other things that are more critical for us, and so affordability and availability wise, it's not likely to come. And so I have largely ignored it for the moment.
Okay.
But you can ask me that tomorrow.
So hold on, before you run off though, like, so what's your view on like the oral, I'm assuming it's like a probiotic, I'm assuming it's just a conjugate of a lot of bacteria. But what's your view in terms of improving immunity based on oral tablets of this nature?
So that's a bit of a loaded question in a lot of ways. Generally speaking, and you may not like my answer, but this is the best one I can give you. Generally speaking, our poor immune function generally over the last couple decades, or increasingly poor immune function, is largely tied to our lifestyle habits. And one of the things that is very clear is that we don't eat enough vegetables, and we don't drink enough water, and we don't exercise enough, and our gut health is specifically impacted by these things. We eat a lot of highly processed foods, we have low fiber in our diet, and the balance of nutrients is not promotive of cellular repair and recovery. So without those good habits, immune function takes a hit. And if we can shift that paradigm, we would do a lot better. I mean, pizza has little or no vegetables on it, but it is a kid-friendly favorite food. Like, my children would never say no to pizza. And so would my mother-in-law. I'm scandaling her now, forgive me. She would never say no to pizza. She loves pizza. I mean, we kind of have to think about what we're giving our body as tools to fight. So the oral things that are available are in some ways trying to substitute for lacks in our protective factors and behaviors. They're not adequate substitutes, but they help. And there are quite a few people who have depleted immune function and depleted capacity for cellular repair and recovery because they're fighting chronic diseases, but they're not maintaining a healthy lifestyle to promote their ability to fight. So those things are helpful when you don't have another choice. But if you can put things in place to prevent that decline in immune function, then you're always better off, even with the little bit of help those additional measures can provide, because it is small. It only gets big when nothing else is going to work.
Thank you.
Thank you so much, Doc.
Thank you, thank you, thank you. So I guess we are what we eat, and we should eat what we grow. So it's another opportunity for you to consider that empty space around your house to start planting more vegetables, right, Doc? So, of course, this is a moment that some of you came here for. I'm just kidding. We're going to move right into our lunch. And our lunch will be plated, so you don't have to go anywhere. And during that period, we'll also do the next presentation. And hopefully you can still focus, you can chew and walk at the same time, right? So we hope the next presenter will still have your full attention. And roll the next slide.
Thank you.
Thank you so much, Dr. James. Lovely, lovely, wonderful. So since you somewhat pulled our leg, we just decided just to reintroduce our line of QRAM dosing. So we have a wide variety, as you can see, of pediatric dosing. So we have the 156.125, we have the 312.25, and the 475. 457. I'm just trying to look, but I should just take from memory. So, of course, the question came up about taste, and we're proud of our taste, lovely banana flavored, as I was told, of our QRAM suspensions. But for the adult dosing, not to be outdone, we do have some special qualities or characteristics of the QRAM tablets. First, they are macrogal free. Now, what is macrogal? Most of you don't invest in knowing about the excipients, but that is one excipient that can contribute to diarrhea or loose bowel, or running a belly, as we say. So with that, it kind of helps to prevent the sort of unintended consequence of taking your medication. And of course, it's also gluten-free. So that's an improvement that you would want to know for some patients that are so much sensitive to gluten. It has no gluten at all. So we're talking about quality medication, quality and effectiveness. When you marry those two together, you have a match made in heaven. So guys, please remember QRAM for all those cases that you need amoxiclav. There's a question? Didn't expect a question. I know this guy for a very long time, so I understand.
All right, the question is, that big word you use, macrogal, yes. Right, free. Is it a new, has it been a change, a recent change with the formulation and the preparation of the medication, or it is something that has always been, for QRAM that is?
It's a recent, more or less it's an improvement. As you know, QRAM are our our labs over there in Europe have always looked and researched methods of ensuring that we are providing the highest and best qualities. So this is a characteristic that is unique to us. So that is, of course, a distinction with a difference that you should know. All right? So we'll have someone just bless the food. So we'll have the servers come out, so you can come out now. And then shortly we'll do the introduction of our next guest speaker. So we'll just ask for, just bow your heads, we'll just thank God for the meal that he has prepared for us. And he will, of course, let it be nutritious to our bodies, and that we will definitely have no gumption or no loose stools, and it will definitely be enriching to our brains as we are about to focus. And so, Lord, we thank you in Jesus' name. Amen. Amen.
Thank you, Lord. Wanna thank you, Jesus, for saving me, making me whole, healing my body. And I wanna thank you, Lord. I'm so glad. I wanna tell the world about it. I love you, Lord. What a glorious feeling. Feels so good in my bones. Hey, 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 hey. What a glorious feeling. So very, so very, so very, so very special. What a glorious feeling. Father, I thank you so much. So special. So special, so special, a special part of my life. So special, so special, so special, a special part of my life.
Mr. DJ. Okay. So, of course, we have to still do some checks as to your registration. So, for those who came in late, the instruction was that if you did not register online or logged in once you were here, then you probably need to do so that we can capture your information so we can send you your certificate afterwards. So if you have any challenge, just raise your hand. If you haven't already done so, then a SANDOZ rep will be coming around to support you with that action. All right, so I take it everybody is already registered. And of course, we will also re-invite you to download our health app. It's called Saludando. We'll put it up on the screen for those who have the ability to scan. Or if you don't, you can go to your App Store or your Play Store. And we'll, you know, like for persons who are influencers, they ask you to subscribe and like. Well, I'm kind of pretending to be one for this minute. So I'm encouraging you to subscribe to our app. So go to your Play Store, download Saludando, or to your App Store and download Saludando before we leave here. I'll be checking on your way out. All right? Thank you so much. And if you have any questions, we'll definitely be able to furnish you with the relevant answers. So as we mentioned, we just want to keep things flowing because there are persons who are online who are a bit jealous that they're not here to partake in the meal. So we won't leave them hanging. So we'll now roll into the introduction of our next speaker, and that will be done by the lovely co-moderator, Gian. Thank you. Yes, give her a little bit of encouragement. Thank you, thank you. Yes.
Good afternoon again. It is my pleasure to be with you this morning and to have the chance to introduce our speaker, the well-accomplished Professor Alverston Bailey. Dr. Alveston Bailey is a graduate of the University of the West Indies, Jamaica, where he earned his MBBS degree in 1980. Post-graduation, he acquired further certification and training in occupational medicine from the American College of Occupational and Environmental Medicine, ACOEM, and launched forth on a long and illustrious career in occupational medicine spanning 4 decades. He was appointed as Chief Medical Officer at the Kaiser Jamaica Bauxite Company from 1984 to 2007, where he served as their occupational physician and medical review officer. In 2010, the University of Technology Jamaica established a new academic program, the Bachelor of Science in Occupational Health, Safety, and Environmental Management, in the School of Public Health and Health Technology. And in 2011, he was appointed as Adjunct Associate Professor in Occupational Health and Safety, with a specific mandate to design and deliver the occupational health modules. Since 2016, he has been an associate lecturer at the Caribbean School of Medical Sciences, Jamaica, CSMSJ, and was appointed as its Executive Vice Dean as at July 5, 2023. He is a past Regional President of the Caribbean College of Family Physicians, 2002 to 2006, and past President of the Medical Association of Jamaica, 2005 to 2007, and now Chairman of the MAJ Foundation, which is the charitable arm of the MAJ. In 2003, he was the recipient of the Medical Association of Jamaica President's Award for outstanding achievements in the field of family medicine, and in 2006, he was inducted as Fellow of the Caribbean College of Family Physicians. In April 2022, he was conferred with the Sir Alistair McIntyre Distinguished Award by the University Diabetes Outreach Program. Since 2008, he is the co-chair of the University Diabetes Outreach Program and has been a spokesperson on diabetes-related issues, as well as a sought-after commentator on public health. He has presented many academic papers nationally and internationally, and is also author of the book Sexplanation, a guide to discussing sex and sexuality in the Caribbean, and several training manuals in his area of expertise. He has also been the host of several radio programs on health issues. Dr. Bailey's professional life has been dedicated to health promotion and volunteerism, and he has worked closely with the Diabetes Association of Jamaica for many years and was appointed as its chairman in June 2021. Since his appointment as chairman, he has rebranded the DAJ and has updated its strategic plan to ensure that its key objectives of training, education, treatment, and research are realized. He has now demitted office as chairman of the DAJ and views with great anticipation the new challenges and opportunities which he will address as the Executive Vice Dean of the CSMSJ. Given all these accolades, one would think that the good professor's work absorbs all his time. However, Prof. Bailey has managed to extend himself to the hobbies of photography, poetry, and cuniculture, which is the agricultural breeding and raising of domestic rabbits. And he made sure to tell me, they're for pets, okay? Not to be eaten. Prof. Bailey is an adherent of Hellenistic philosophy, which are the philosophies of Aristotle and Marcus Aurelius, which advises to lead a virtuous life. So in the subject of ethics, Prof. also chooses to lead with virtue ethics, which central concepts include, of course, virtue, eudaimonia, and phronesis, or practical wisdom. Ladies and gentlemen, please help me to welcome to the podium, presenting on the topic, Navigating Ethical Dilemmas in Antimicrobial Stewardship, Balancing Patient Care with Public Health, the cuniculturist, photographer, and philosophical poetic professor, Alverston Bailey.
You're too kind. Sometimes I'm introduced and I can't recognize myself. It's really a pleasure to be here. In fact, I deliberately isolated myself during COVID, and this is just the second time I'm coming out to share a face-to-face talk with you, my colleagues. It's a pleasure to see you here and to meet a lot of old friends. My topic today really is meant to encapsulate and put in proper perspective all that you have been exposed to so far. It was for me in preparing this presentation a fascinating journey of discovery, and I anticipate that you will also enjoy this journey. Let me make sure that I'm pressing this properly. Which one is up? The right, oh, there you are, there you are. So my topic today really is looking at the ethics of antibiotic stewardship. This lecture will provide you with an overview of the rationale and justification for established antibiotic stewardship. It will give you an overview of the dominant ethical theories, and I will pause to discuss with you 3 ethical scenarios to guide you with the best options to choose when prescribing antibiotics. You'll note that all my slides have the appropriate references, and feel free to take a snapshot of them so that you can go and read the paper yourself. Antibiotic utilization from its inception has had moral and ethical problems. In Alexander Fleming's often referenced 1945 Nobel Prize acceptance speech, he says that the hypothetical scenario of a patient's death from penicillin-resistant streptococcal pneumonia places the moral responsibility for this death on the patient who inappropriately dosed penicillin during a prior infection. More than 75 years later, Spellberg, in a paper published in JAMA, argued that antibiotics remain a unique therapeutic class whose population-level efficacy is reduced with excessive and inappropriate use. And this, in fact, I want you to reflect on, because you're going to have to make a decision whether your treatment for your patient, which is individual patient, can in fact impact on the population, or your treatment of the present patient could have serious impact on future patients. The direct effect of this overuse, called antimicrobial resistance, has downstream epidemiological, medical, financial, and societal consequences. In 2019, the CDC Antibiotic Resistant Threat Report estimate that 2.8 million antibiotic-resistant infections occur annually in the United States, resulting in 35,000 deaths and 4.6 billion in healthcare costs. The WHO and the UK government have also published reports estimating that global annual AMR-associated deaths could be upward of 300 million by 2015, and with an estimated additional cost of 1.2 trillion in healthcare expenditure. Although addressing AMR has mostly been reserved to the arena of public health and public health policy. The issue, scope, and complexity also has ethical implications, according to Littman and Nathan. Discussions regarding the ethics of AMR are focused primarily on the need for international surveillance, guidance, and policies to ensure equitable distribution of antibiotics where they're desperately needed. Jog and Laibo Vichy in 2012 and 2016 in their paper argued that prescription of antibiotics presents an ethical dilemma for physicians, and current health needs of patients have to be balanced with concerns for their safety due to adverse effect and restricting antimicrobial resistance throughout the community. Lax Minarayan, in his paper in 2013, called Antibiotic Resistance, the Need for Global Solutions, concluded that overuse of antibiotics is a major pathway for development of AMR, which adversely impacts pollution health by increasing mortality and disability, escalating treatment costs, and reducing economic productivity. Again in 2016 reminded us that the alarming increase in AMR is a major public health challenge worldwide. Therefore, I concur with Doran, who reminds us that promoting judicious use and avoiding irrational prescription of antibiotics is considered a key strategy for containing AMR in communities. I thought I would like you to take a look at this slide, which looks at the inappropriate use of antibiotics. And we need to look at a number of concepts: overuse, misuse, underuse, and abuse. And as you can see from the slide, many of us are guilty of overuse, of misuse, underuse, and abuse. And so I'm now inviting you to put on your ethical caps. Going forward, we will avoid these challenges. We will not overuse. We pledge not to misuse. We will not underuse. And we will not abuse antibiotics. Let's look a little bit more on inappropriate use of antibiotics. Taconelli et al. Did a systemic review published in 2008 and concluded that the risk of acquiring methicillin-resistant Staph aureus was increased 1.8-fold in patients exposed to antibiotics. Paul and his team in 2010 observed that prescribing of ineffective antibiotics for patients harboring resistant organism was associated with a 1.6-fold increase in mortality from infection. The next slide actually looks at the main organisms that are currently problematic in North America. They have a nice name, actually. It's easy to remember. They're called escape pathogens. And they're pathogens that we're all familiar with: Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter species. But I had a talk with one of the presenters this morning, and he reminded me that we need to now call it SKP by including E. coli. So these are the main escape pathogens which we need to be aware of. I actually created this slide because it left me a little confused in that there's so many antibiotics on it that I had never heard of. So I had brief dialogue with one of my colleagues from Bustamante, and he did tell me that many of them are in fact here. But the reason why I'm not familiar with them is because I'm not involved in critical care. But what it actually indicates, basically, is that when one has to deal with anaerobes, gram-negatives and gram-positives, that there are many of these antibiotics that can, in fact, treat all the above. And we need to use them with caution. Now let us look at what's happening to us doctors. A survey of doctors in a teaching hospital in 2004 reported that 90% of doctors, like ourselves, wanted more education about antibiotics, with only 21% feeling very confident that they were using antibiotics optimally. It would be interesting to do a survey among all the doctors here in this room and online to find out how many of you really are confident that you're using antibiotics optimally. Minen in 2010 did a survey of more than 300 medical students in the USA and reported that at least 3/4 of the cohort expressed a desire for more education about choice of antibiotics. And another survey done in Scotland in 2011 suggested that 75% were confident about choosing the correct antibiotic, but only 36% about the duration of treatment. And that was a question I asked this morning, and it was raised that apparently we are over-treating our patients. And therefore, it is incumbent that we get appropriate guidelines to inform our prescribing habits. So let us look then at the main event this afternoon, antibiotic stewardship. McCowan in 1996 reminded us that antibiotic stewardship was intentionally coined to emphasize its ethical nature, with stewardship meaning the judicious use and protection of unlimited resources. I remember many of our colleagues this morning reminded us that antibiotics remain a limited resource. The term antibiotic stewardship has now been adopted widely to encompass initiatives that promote the responsible use of antibiotics. And the goal is preserving their future effectiveness, and I want to emphasize this point. The goal is to preserve their future effectiveness and safeguard public health. There are many different components to antibiotic stewardship, which is mentioned in this slide. But I really want the take-home point for this afternoon to be for you to remember the 5 R's. You, as stewards, must make the right choice. You must ensure that you give the right dose. You must give the medication at the right frequency. You must choose the right route. And this is the big one. You must ensure that you give it for the right duration. Because antibiotic stewardship involves and impacts on treatment outcomes, food security, economics and industry, politics. It involves the health of man, animals, and birds, and it involves the onset of antimicrobial resistance. So how does ethics come into the picture?
Well, I want to remind you that there are 4 branches of ethics. And I'm particularly fond of ethics because it makes it so easy for us to make the right decisions. We have descriptive ethics. What do people think is right? We have meta-ethics. What does right even mean? We have normative ethics. How should people act? And then we have applied ethics. How do we take moral knowledge and put it into practice? So this slide actually shows you the different dimensions of ethics. Meta-ethics, prescriptive ethics, descriptive ethics, and applied ethics. We're going to go through them quickly. Meta-ethics is fascinating because it is a discipline concerned with determining the meaning of ethical terms. So meta-ethics actually would like to find the nature and meaning of our moral judgments and actions. So meta-ethics is a philosophy which says, if stealing is immoral, why is it so? If charity is moral, why is it so? When we say honesty is good, then what do we mean by the term good? These are going to leave some interesting thoughts in your mind this afternoon. So meta-ethics says it doesn't consider whether an action is good or bad. What it questions is the goodness and badness of morality itself. That's getting kind of deep, so let's move something a little easier to understand. Prescriptive ethics looks at what we ought to do. So, it is a study of moral behavior that seeks to discover how one ought to act. Not how one does, in fact, act, or how one thinks one should act, but how you ought to act. And this therefore takes us into the realm of virtue, which is a philosophy that I adhere to very sincerely. Then we have consequentialists and deontologists. So virtue really is a broad concept that emphasizes character. And it encourages you to be honest, courage, compassionate, generous, faithful. You should have integrity, fairness, self-control, and be wise. A person who is virtuous will be disposed to act in ways that are consistent with good morals. Now, teleology basically is also called consequentialist. And I want you to look carefully at this because this is important, especially when we're looking at antibiotic stewardship. Basically, this holds that the consequences of your actions is the ultimate basis for judgment. Therefore, a consequentialist is interested in that what you do will produce a good outcome. And I think I want you to look at this slide and tell me what you think in your own mind. That a consequentialist, i.e. you're going to dispense some antibiotics, all in general, that an act is right if and only if the act, or in some views, the rule under which it acts, will probably produce, or is intended to produce a greater balance of good over evil. So you do what you have to do because it is a good thing to do. On the other hand, deontology is a branch of moral philosophy which does not focus on the action, which actually focuses on action but not the outcome. Therefore, it says that some actions are good or bad regardless of the result. Therefore, it says certain actions are always right, always wrong, and the results are inconsequential. So lying is always wrong, even if it can save you from the gallows. A hacker is always wrong, even if it can prevent a nuclear war. So these are thoughts for you to reflect on. So if someone should be helped, if you are a consequentialist or utilitarian, you'll point to the fact that the consequence of doing so will cause maximum well-being. If you're a deontologist, you'll say that in doing so, the agent will be acting in accordance with a rule. Do unto others as you would be done by. And a virtue ethics will say, do what is right and be charitable and kind. Descriptive ethics basically really is the study of ethical beliefs and behaviors, and we won't get into that. And so we now move to bioethics, which is a part of applied ethics. It includes environmental ethics, cyber ethics, and so on, but we'll just zoom in on bioethics, which is what you're quite familiar with, which is beneficence, justice, non-malfeasance, and autonomy. So, antimicrobial stewardship carries an intrinsic ethical dimension, and most ethicists recommend that a formal, explicit application of ethical principles inform antimicrobial stewardship. And this was actually based on Boucham and Childress' concept of ethics, which you're all familiar with, which essentially is autonomy, the right for the patient, and in stewardship, we include the prescriber to make medical decisions for themselves. Let me repeat, the right for the patient to make medical decisions for themselves. Justice, balancing societal and individual good. Non-malfeasance, avoiding harm to patients. And beneficence, acting not just to prevent harm, but also to benefit the patient. In order to explain this concept, I'm going to invite you to come with me along this journey by looking at 3 scenarios. This will look at the impact of stewardship on the individual, the institution, and the society. The first one is called the prisoner's dilemma. This is a situation in which 2 accomplices are accused of a crime. Both are offered the chance to give up their partner in exchange for a reduced sentence. But by doing so, their accomplice will serve a longer one. To win, both people must agree in advance not to give each other up, thereby minimizing the consequences for both parties. This dilemma highlights how people, when given the opportunity, prefer communication and cooperation to reduce risk and maximize benefit. So Spellberg, back in 2014, suggests that we can translate the theory into inpatient or outpatient medical practice of the prescriber's dilemma. The prescribers believe that patients are seeking antimicrobials, and patients believe the same. But they do not communicate their goals. And so there's this unspoken assumption carried by both the prescriber and the patient that each will do what is the right thing to do. So should the prescribers or patient's autonomy supersede the need for the wider community to reduce antimicrobial resistance? In a narrow spectrum antimicrobial, or none at all, an acceptable level of risk exists for the patient and prescriber. So, how can we as stewards serve as allies rather than being antibiotic police and get involved in judicious antibiotic prescribing? One example of an antimicrobial ethicist solution to the prescriber's dilemma is to look at trials. And this is an example of a trial that was done by Mika in 2014. And he enrolled 14 physicians who practiced at 5 Los Angeles clinics. 7 clinicians displayed a public commitment poster printed in English and Spanish and written at the 8th grade level, signed by the clinic's provider, promising to provide antibiotics wisely. This low-cost intervention resulted in an absolute reduction of inappropriate antibiotic prescriptions for acute respiratory infection without a reduction in appropriate prescription. This indicated that when the patients were aware of the rationale for antibiotic care, they were more cooperative and more inclined to listen to the doctor. Thaler et al. Suggests that by implementing what the authors call a nudge, a term coined by behavioral economists, they help create an environment that enhances ethical decision making. This intervention, therefore, enables both parties to win the dilemma by ensuring what is called shared decision making. If we get involved in shared decision making, it will accrue beneficence to do good to the patients and non-malfeasance to do no harm. It also limits antimicrobial stewardship encroachment, especially those set by the facility in which you work, and will be regarded as just. And so it will provide justice. So by tapping into the preference for cooperation and communication, we will enjoy what is described as shared decision making. Let us look at scenario 2, which actually is called pre-authorization and prospective audit and feedback. In the 2016 Infectious Disease Society of America for Healthcare Epidemiology of America Antimicrobial Stewardship Implementation Guidelines, the ethical guidelines recognize that there are 2 issues: pre-authorization or lack thereof, and prospective audit and feedback. So 2 potential ethical pitfalls of these interventions were noted. The guidelines had limitations to autonomy and the avoidance of truth-telling, i.e., there was limited communication between the doctors and the patients. As it pertains to antimicrobial stewardship, the goal is to create an environment that encourages physicians to tell the truth. It also prevents you from bypassing indications or withholding information. To ensure that antimicrobial stewardship programs are not acting capriciously or in an unethical manner by excessively limiting prescribers' autonomy or comprising truth-telling, it's important that the institution develop what is called a consensus guideline or matrices to inform the dispensing of antibiotics. But even if you do so, you have to bear in mind that you could do harm, and you must ensure that it is beneficent and that you act wisely. Some of the common use matrices, which is important, especially in hospitals, are the days of therapy or the defined daily dose. But in many cases, even though you suggest days of therapy or define daily doses, you cannot directly gauge their proper use. Other information that should be given would be the indications for diagnosis, the local antibiograms, and compare your prescribing habits with your peers. There's another approach that has been recommended for antimicrobial stewardship, which is called the standardized antimicrobial administration ratio. This provides appropriate benchmarking to highlight potential areas of inappropriate usage, but again, it cannot guarantee appropriate usage. This particular approach, the standardized antimicrobial ratio, compares actual to expected antimicrobial use. And I'd like to invite you to take a screenshot of that particular slide and look up the methodology for establishing an SAR in your institution. Therefore, continued work by the antimicrobial stewardship community is needed to better establish proper matrices for appropriate usage. And this process will encourage truth-telling by the doctors and will highlight the value of antimicrobial stewardship to everyone. There are two new areas of infectious disease and antimicrobial stewardship that I'd like to tell you about. First, there are ongoing clinical designs looking at more holistic approaches to the management of antibiotics in healthcare. There is, in fact, a particular guideline that is called the DOOR guideline. This is called the desirability of outcome ranking. And basically, it channels the philosophy of cure or not cure, survival or mortality, by ranking a spectrum of outcome based on benefit and harm. This particular approach was constructed to provide better overall clinical outcome and shorter duration of antibiotic use. So this approach, the desirability of outcome ranking, has been shown to combine multiple clinical outcomes and antibiotic regime in a single metric. And this approach therefore places value on treatment, which aligns to virtue and not just outcome, which is consequentialism. Therefore, again, I'd like you to take a look at this slide, which you can take a screenshot of and read up on the approach to unlocking the door. Unlocking the door, because it serves as a useful endpoint in antibiotic trials by comparing a range of efficacy and safety outcomes in a single matrix. DOOR, therefore, strives to provide healthcare professionals with the resources to make well-considered, ethically nuanced decision that balances the benefits of antibiotic care versus harm. Another approach that has been used is to use qualitative or mixed method stewardship, which help to identify ethical components involved in antibiotic stewardship. Sharani and his team actually conducted a survey of surgical and medical team prescribing habits, looking at key differences in patient autonomy, decision-making, and responsibility. And he found that the behavior of patients and ethics of patients and of physicians played a critical role in the use of antibiotics. The final scenario is called the runaway trolley. And this one is quite interesting. Whereas the prisoners or prescribers dilemma only involves two stakeholders, this classic ethical dilemma of the runaway trolley invites us to consider how to justify the moral and ethical decision to save one person versus 5. And I actually thought this was quite interesting because many of the papers I read to prepare for this presentation argues that it is better to compromise care in the present to prevent severe challenges in the future. Think about that. Now, in its most rudimentary form, a runaway trolley is careening down the track towards 5 bystanders. If left to run, it will kill all 5 individuals. However, you as a doctor can flip the switch to another track and only 1 bystander is killed. Which switch do you flip? Do you flip the switch to kill 1 bystander? Or do you flip the switch to kill 5? Bearing in mind that thou shalt not kill. So you have a problem. So, this particular scenario highlights our ethical theories such as utilitarianism, which I'm sure most of you agreed with, that you should flip the switch to kill 1 versus 5, means quantitatively saving 4 more lives than you would have if the trolley had not diverted. And this can play out in antimicrobial stewardship. There have been many persons in the health sector who work in intensive care unit, and you won't have limited supplies of a particular antibiotic. Who do you give it to? The young, the old, the disabled, the laborer, the professional? Please don't tell me, just think about it. We have to make these challenging decisions all the time in medicine. Now, choosing and implementing intervention will benefit the wider society or the population, collective level, or it will benefit the individual. So you now have a choice between saving 4 versus saving 1. Which decision will you make? Now, you must realize, therefore, that this concept of antimicrobial stewardship has consumed the mind of a lot of ethicists. And so, in fact, in 2021, there was, in fact, a campaign called Choose Wisely, which I think is really neat. And so, again, I'm going to invite you to take a screenshot of that particular site and look it up. How do you, as physician, choose wisely? The goal of the Choose Wisely campaign was to initiate conversation between clinicians and patients. And this is important. Initiate conversation between physicians and patients. And most of us find that very uncomfortable because we're in charge. This initiation of the conversation is about what tests and treatments and procedures are needed and which ones are not. And it began in 2012 and is ongoing. The campaign, therefore, is meant to help patients have conversations with their clinicians and empower them to ask questions about what tests and treatments were right for them. That's called autonomy. And that is something which most of us find very difficult to consider. To have conversation with the patients and empower them to ask questions about what tests and treatment were right or wrong. Another emerging example on a local level, which I'm sure is practiced in many institutions, is the concept of expected practice. Expected practice, I think, should be encouraged. And this is where an institution expectation of all providers should practice medicine is laid down in regulation. And this might enforce stronger standards of care compared to clinical guidelines. Expected practices were developed and implemented by a coalition of primary and specialty care specialists and approved and given to medical staff to guide them. So therefore, expected practice are meant to be more robust and tailored to the institution than professional safety guidelines. We could argue about it, but that's what experts believe. They believe that if the facility have an expected practice approach, it will facilitate buying of the hospital leadership using data available in that particular institution. So the act of achieving practice consensus and codifying collective expectation means that the institution has bought into beneficence, do no harm, to do good, and non-malfeasance, to do no harm. I thought I'd just look at the whole concept of shorter antimicrobial therapy. Just over a decade ago, the concept of shorter antimicrobial therapy was considered dangerous, like when I left med school, and even unethical, given a lack of well-designed studies and concerns that we are going to cause harm. And I, in fact, when I graduated, was quite happy to give antibiotics for 14 days, even 21 if I think I'm going to do good. But in his landmark study in 2008, Maxwell lecture, Dr. Louis Rice challenged the infectious disease community to re-examine this long-standing dogma related to antibiotic duration. He highlights the harm, such as antimicrobial resistant and Clostridial disease difficile infection. So he argues, by weighing the beneficence and non-malfeasance of longer versus shorter courses of therapy, Dr. Rice called for evidence-based and ethical clinical decision making. And I particularly like this term. Anything I like, I tend to highlight it. And if I like it, I'd like you to like it too. Eminence-based medicine. When I was in med school, most of the medicine that I practiced was based on my professor's recommendation. Eminence-based, because they were the experts and they knew everything, right? But he's arguing that we must now go on for evidence-based rather than eminence-based. Since then, thank goodness, multiple clinical trials spanning a broad range of common infectious diseases have confirmed. And I like this, and it is in red. And I like red. So, it shows that, with few exceptions, shorter duration of therapy do not incur greater patient's harm while they achieve the same favorable outcomes seen with longer doses. This is my best slide. You can screenshot it until you run out of power. Good slide. These findings have been so compelling that they now feature as practice guidelines, not only for infectious disease specialists, but also internists. And this reference is stated clearly in the slide. This significant paradigm shift by emerging scientific data illustrate the ongoing need for ethical re-examination of antimicrobial stewardship best practices in the future. So, in conclusion, should the ethical nature of antibiotic stewardship be explicitly articulated or not? I strongly believe that there is real value in the recognition and articulation of the ethical dimensions of antimicrobial stewardship. First, an ethically informed approach to antimicrobial stewardship will align programs to work with CDC core elements and regulatory requirements that center on safe and effective patient care. Secondly, using a robust ethical framework to inform priorities and implementation of programs with key partners in infection prevention and control, paying attention to environmental health, working with employee and occupational health specialists and others in hospital leadership will enhance the framework. Further, such a framework makes the use for stronger institutional support and resources dedicated to antimicrobial stewardship. And that particular slide is entitled How to Pitch an Antimicrobial Stewardship Program in a Hospital. For those of you who work in hospital, take a screenshot and start pitching. Thirdly, an emphasis on the ethics of antimicrobial stewardship will complement the application of behavioral frameworks in antimicrobial stewardship to encourage a change in culture within the institution, because change is a difficult process. Fourthly, these ethical imperatives will drive scientific research and innovation, emphasizing evidence-based and best practices. However, none of these benefits will accrue passively. They will occur through practical training in the application of biomedical ethics for antimicrobial steward and active engagement of these topics within the community. Without doing so, we will lack shared ethical resources and moral imperative to stem the tide of a looming global crisis of antimicrobial resistance, which, based on the evidence I presented to you, is a slow-moving pandemic marching relentlessly forward. I thought this slide was interesting, in which the young intern said, "Day 3 of prophylaxis, sir. Can I stop it now? I'm pretty sure there's no infection." And the expert, the eminent surgeon, said, "Just one more day to be sure. I deal with the antibiotic police outside," because he is the expert. I inserted this just about an hour ago because I thought I need to tell you this. It might be dated, but it doesn't really matter. This explains what the Access, Watch, and Reserve is all about. And get your, I think you should get your apps ready to take some shots. I like when people take shots because when I give a talk, I want to be remembered. Because as a Stoic ethicist, I want to be long remembered. And therefore take shots generously. And I like it because it says access means available at all times as treatments for a wide range of common infection. Watch. Antibiotics that are recommended as first or second choice for a smaller number of infection. Reserve. Last resort. Take your time and look at it. Last resort. When all other alternatives have failed. So you're standing by now for the piece de la resistance. You're standing by now to see what these are. And I'm not going to disappoint. I'm going to show you. I hope you can read it. If you can't read it, imagine. Doesn't matter. Just go online and look it up. It's green, yellow, and red. And these are not all the antibiotics that you have available, but it speaks for itself that there are some antibiotics which I use all the time, like quinolones and fluoroquinolones and macrolides, which I really should be reserving for more serious infection. But I use quinolones generously in my practice. Why? Because they work. Am I over-treating? Of course I'm over-treating. Because my patients want to get better fast. It's something that we all have to grapple with. But am I doing good for the present to create problems for the future? The answer says apparently yes. So as a virtual ethicist, I'll reconsider my approach. And having heard about access, watch, and reserve, I will definitely consider changing my prescribing behavior going forward. The references are stated. And I thank you for affording me the opportunity to share my thoughts with you.
Thank you so much, Dr. Al Bailey. So we now open the floor to a few questions. I'll be coming around. You can come to the front. Are we having any questions online? Okay. Dr. Bailey.
Hi, good afternoon.
Good afternoon.
In relations to the topic which you presented earlier, inappropriate usage of antibiotics, right? When a patient has a Clostridium difficile, which we all know as C. diff, right? And they've been given the prominent medication vancomycin. How effective is vancomycin when given orally, opposed to it being given intravenously?
I'm going to yield to my infectious disease consultant because you're asking a question that we rarely have to deal with in general practice, and we normally yield to the specialist, and she will now answer that question.
Oh. Hi, everyone. Sorry. Okay, so vancomycin is a special case. It does not cross the blood-gut barrier. So vancomycin in your gut is not going into your bloodstream, and vancomycin in your bloodstream is not going into your gut. So you cannot use intravenous vancomycin to treat a C. difficile infection. It will not work. So you can only use oral vancomycin for C. difficile infection in the gut. There is no crossover. And this, for example, if I have a patient with a multi-drug resistant coagulase negative staphylococcal infection in the bloodstream, and they have C. difficile associated diarrhea at the same time, that patient would have to receive intravenous vancomycin at the same time as they are receiving oral vancomycin, because you're treating two different infections with the same drug, but it will not cross over to cross cover.
Thank you very much, my colleague, and I would recommend you stay with me.
I'll go sit.
Thank you. So there's a follow-up. Okay, she wants to rebut. No, sir. Oh.
Okay, thank you very much for that information, madam. Generally in the hospital, right, when patients have a C. diff diarrhea, right, when they have the diarrhea, and the doctors recommend vancomycin, we usually get it in a vial, right, in an ampule, right, vial, and you constitute it in like 10 cc of normal saline. On the vial, it says IV/IM. So how is it that the doctors are recommending it PO?
So that one's an easy one, and it's about levels of usage. Oral drugs cannot be crushed and put into the bloodstream because they have excipients made for gut use that are not safe for intravenous administration. But IV and IM drugs can be given orally unless the drug does not effectively get into the bloodstream that way, but they are safe for oral administration. So what that means then is we are just cheaping it out. The tablet version of vancomycin is far more expensive than the liquid IV preparation. So we are in a resource limited setting in the Caribbean, and we're not going to purchase the expensive stuff because it's not going to change what the patient will get. It just tastes different. The niceness of the oral one is that the patient not to taste a bad taste in vancomycin. The IV drug tastes really bad, you know. So it's best to mix it in something very nice tasting. But other than that, it doesn't change anything. When the doctor writes vancomycin slurry, all it is, as they're saying, you know, use what you have, mix it up in something and give them to drink. Just make sure it's something that tastes nice, because it tastes really bad.
Okay. All right. So am I getting questions coming from the floor? Do we have any online?
I have a comment.
Oh, there's a comment. Sure. Go ahead.
So, Prof, thank you so much for such an engaging presentation. I loved it. So I wanted to give an example for everybody of this ethical dilemma, because it's a pet peeve of mine, just because I see it so often. We tend to treat ourselves as physicians very often. We want to feel that we are doing the right thing, and we don't feel safe to not treat very often. So we often are on the side of treating as opposed to not treating. But particularly where it concerns urinary tract health, this becomes a very big challenge. Very often, patients coming in with vague symptoms of being unwell, possibly having an infection, and you get a dipstick of the urine and it has leukocytes and nitrites, and you say, okay, this is a UTI, I am going to give antibiotics. And we know that the average, especially female more than male patient, has asymptomatic bacteriuria very commonly because we have a short urethra. The germs get up into the bladder very easily, so they're present. But bacteria being present doesn't equal infection. So when you then take that patient with asymptomatic bacteriuria who does not have a urinary tract infection, you give them a broad spectrum antimicrobial agent, usually Cipro, kill off all the good gram positives and gram negatives and the few little anaerobes that aren't causing a problem, and you leave behind all the pathogenic drug resistant bacteria like the Enterobacteriaceae that are intrinsically resistant to a whole host of antibiotics. Then what you set the patient up for in the future is the next time their urinary tract is vulnerable, they're going to get a UTI.
with a worse germ than usual, and their ability to recover in the future after these multiple courses of antimicrobial administration is going to be less and less and less. And this has led to a phenomenon of certain female patients in particular, because it usually happens with us women, of having recurrent UTIs, and they just can't get rid of them. As they get rid of them, they get another one. Very often, not all the time, we have caused that by not being good stewards and differentiating the actual cause of their problem as opposed to labeling it with what we feel comfortable. So I just thought I should just, throw that out there for consideration.
Thanks much. And I think that every physician here would say guilty as charged. That's just how it is. And I'm very intrigued by this presentation, because I think that by the end of the session, our own approach to stewardship would have changed significantly. We start to think about the ethical issue of inappropriate antibiotic prescribing. Yes, sir.
Yes, I'm so glad that you came up with it. Guilty as charged. Now the question is, what do we do in light of what you just told us? Because some persons will come in, every time you see them, it's the same profile that you're getting, whether you do dipstick or whether you do the microscopy sent to the lab, and you get the same profile over. The patient themselves, ethical issue, will become concerned and say, why is bacteria in my urine? Why is all of that stuff? Why can't I have a clear urine just as other persons? And especially if it has been occurring over a long period of time, you tend to start to wonder, number one, is there any harm to the patient? And so you want to see how can I get rid of this? Do we resort to just leave it alone, or do we resort to say, oh, go man, drink some cranberry juice, make sure that you hydrate properly, all of that stuff? What other measures are there can we do so that we avoid abusing the antibiotics?
You can go ahead. No. You're the expert.
So I have to go back to the first presentation. In the first presentation, there was a very important set of statements, and one of them addressed this specifically, because it's something that we battle every day, but so remember that we were talking about, Doc mentioned the gut having more bacteria than the cells in our body, right? Every section of your body has more the external surfaces, which includes the gut, has more bacteria than the cells in your body, billions and billions. We cannot be sterile because we do not live in a bubble. There is no way to sterilize the body, and sterilizing the body would not make you safe. Sterilizing the body would make you more vulnerable, because then the first one to come, if he happens to be the thief or the murderer, is going to steal, kill, or destroy. So we want our normal flora. We want our happy, commensal, friendly germs to live with us, because they take up space that a pathogen would want to occupy. But because the pathogen comes along and finds a space already occupied, they're not able to take hold. But when we get antibiotics and we kill the very susceptible normal flora, we leave empty houses. So they're fully furnished and waiting for people to come in and occupy them. And those particular germs will be whatever we're exposed to. And that is even more significant for those of us in the healthcare industry, because we're exposed to germs that are exposed to antibiotics, and we're going to get them, and our families and our friends. So that's a vicious cycle that we don't want to engage in. We want to avoid that vicious cycle. We need our good germs. If you want sterility, you have to become like Bubble Boy. You go live in one of them things and don't expect to interact with your environment.
Well. So we have one last question, and we're gonna take it from online, because They've been somewhat sidelined in this discussion. So can we bring somebody from online?
So the first question is from Dr. Anna Brown Morgan. How dangerous is overtreating by a few days in our society? If the medication worked, there would be no risk then of resistance, would there? And we know that the patient often won't return for quite a while. The treatment regime always requires review of the patient. What then is really ethical to ensure success is also important?
Now, I'll address that and then you can follow. That's the ethical dilemma we face. We want to ensure that the treatment is efficacious, and we want to guarantee that the patient doesn't return with the same infection. And so we tend to err on the side of caution and overtreat. The risk involved, as my learned colleague just said, is that you will end up exposing the persons to the risk of resistance in the future. So basically, it's kind of short-term gratification for long-term pain. And it's not only the patient who might develop resistance, but those with whom he or she comes in contact with might also get those resistant organisms. So it will require a lot of self-control, a lot of wisdom, and most importantly, I think the time has come for us to really start to circulate appropriate guidelines with respect to antibiotic treatment. An annual guideline to all doctors looking at evidence so that we can do what is best for our patients rather than what we think is best for them. You can respond now.
All right, so I agree with you, Prof, very much, but I want to add some things. So when we look at it on an individual case-by-case basis, it would seem that that's okay and there's not a problem. But the studies that have been done on this show that on a population level, what you're doing is, one, not giving any additional benefit to the patient, because once the germs that are targeted are killed, there's no additional benefit to the patient to giving more antibiotics. But you are increasing a lot of potential risks. One, side effects from the drug. Two, the more you give it, you're killing more germs that you don't want to kill. And when you look at the risk of, swinging in the other direction, so you move from harm to benefit to a different kind of harm, everything that can cause a benefit could potentially cause a harm. So even though drugs are treatment, they're also potentially poison. It may not affect everyone, but then if you are increasing the risk of adverse effects and adverse events in 50% of people, just for argument's sake, is that ethically acceptable to be giving an additional harm, which is making you feel comfortable that you are doing something good by treating the patient, but you're giving them a period of treatment and exposure to a chemical they don't need that will not benefit them and could cause side effects and downsides. That in itself, to me, is a fairly clear ethical dilemma. You've passed the point of benefit and you are now heading towards harm.
Very well said, Doc. Thanks much.
Another question online. Dr. Bailey, what is the difference between medical ethics and legal ethics?
Medical ethics and what?
Legal ethics.
Well, that's a completely different thing. Medical ethics, that's basically applied ethics. Medical ethics has to do with addressing the concerns that doctors have in relating to and treating patients, whereas legal ethics has a much wider scope because lawyers as a rule do not have patients to deal with. But there's an overlap because the truth is, now you come to think of it, in legal ethics, you must display justice. You must do no harm, and you also must do good. So there's an overlap. It's just that contextually, the clients and customers that you have to deal with are really different. One has to deal with addressing medical problems as distinct from addressing legal problems. And my gut feeling is that lawyers must be ethical and so should doctors. But I think the bioethics which applies to medicine is far more complicated and has far more long-reaching effect, because when we, especially with respect to antibiotic stewardship, the good we do, the perceived good we do now could translate into harm in the future. So I'm not sure it's an appropriate comparison, but there's a strong overlap.
Okay, thank you so much, Prof. So that's it. Thank you for all your questions. Wonderful, wonderful. So as they say, with all good things, at some point,
must come to an end, right?
and indeed, it was a day well spent. And you
Indeed.
were an exceptional audience, I must say.
Yes.
With this sort of audience, I could just take you everywhere with me. You're so attentive, so well informed, and you asked some really good questions.
Yes.
And you would be better off for it. I know you could have been somewhere else on a Sunday.
Right.
Okay. So we have some dessert for that to take home with you. But definitely, we had some excellent presenters.
Definitely, definitely. So we're going to move into the vote of thanks at this moment.
Indeed, and we'll now invite our colleague, Miss Sana, Mrs. Sana Pitkin-Cover, to do the honors. Welcome her.
Thank you for the beautiful welcome. Good afternoon, everyone. I know the days ended, but I didn't get that big, robust good afternoon that everybody else got. So good afternoon, everyone. Thank you, I appreciate that. Thank you for joining us at our first Hybrid Health Summit for 2024. On behalf of all of SANDOZ, or product managers, or FLM, and by extension, the Jamaica team, I would like to officially thank everyone, both seated here and all those who have logged on online. My heart fills with gratitude and respect for our distinguished presenters, Dr. Curtis Price, Dr. Pate Robinson, Dr. Marsha James, and Professor Alvaston Bailey, for not only sharing and sparing their invaluable time, but also for enlightening us with their commendable talks. Indeed, you have put your best efforts into making this event unforgettable. Thanks to the AGPJ and their partnership, and a special thanks to Lynn Thompson Hyatt, who has been instrumental in the administrative aspects of making today a success. Thanks to the moderators and the audiovisual team for ensuring that this hybrid meeting flowed smoothly. Thanks to Terra Nova Suites and Hotel for the administrative team and wait staff for providing a comfortable space for us to have our meeting with superb service. Today was enlightening, with thought-provoking sessions from which we will continue to thrive to improve patients' well-being and lifestyle. As you all make your way to your different destinations, I wish for you safe travels. And again, we thank you.
Thank you so much, Sana. So you know what comes after? You're gonna get your CMEs in your emails, and it's 4.5 CMEs. And as soon as you get it, please take a screenshot so we don't lose them, so you can submit when you need them. Thank you so much. and have a good rest of the day.
Sandoz is an internationally renowned pharma company with unique heritage in generic antibiotics. Our key antibiotics site is Kundl, Austria, where our products have been manufactured for the past 7 decades. It's a large-scale antibiotics plant that integrates all production steps into a single process at one site. Each process fully complies to the GMP standards, ensuring quality at every stage. We develop and introduce innovative manufacturing technology for both active pharmaceutical ingredients and finished dosage forms. A broad range of analytical methods is used to analyze the different products, from tablets to sterile injectables, with automated systems to standardize quality control. Our manufacturing areas are equipped with clean rooms to avoid any contamination. The sterile filling area is hygienically completely separated with controlled air quality, overpressure, and special clothing for the operators. All products are tested in our in-house quality control laboratories before any product batch is released to the market. We are proud to have a fully integrated production chain whereby all stages of manufacturing can be performed in-house. This enables us to ensure quality of our products throughout the entire manufacturing process. Antibiotics remain the backbone of modern medicine. That's why Sandoz invests in Kundl facility to increase manufacturing capacity and to upgrade technology to support rapidly growing patients' needs.
Sandoz is the global market leader in generic and biosimilar medicines. Whatever we do, we put the needs of patients first, making high-quality, cutting-edge medicines accessible to more patients, whenever and wherever they need them, and at prices they can afford.
Hey, this is the new way to support your treatment access. Say hello to the Saludando plan. Would you like to know how the savings and discounts mechanics work? Let's take a look at Cece's case. She goes to her favorite pharmacy to buy the medicine her doctor prescribed. At the pharmacy, Roger kindly assists her and talks to her about the new discount Saludando plan by Sandoz. Roger signs her up very quickly and just like that. After buying her first medicine, she will already be saving. Some days later, Cece returns to the pharmacy for a new purchase. Roger greets her with the great news. He checks the Saludando website and sees that she has accumulated savings. He tells her the balance, and now she decides. She can either use the accumulated balance or just a part of it for this purchase. The discount will become effective and she will only have to pay for the price difference. If she decides to keep saving, she'll be able to use the balance in her next purchase. What happens if she has an accumulated balance that is higher than the product price? Saludando works using immediate discounts. It reduces amounts lower than the full price of the invoice. Cece can use the accumulated amount closest to her invoice, and the rest will be kept in her balance. Saludando offers a benefit with every purchase, and not just once in a while. It can be used from the first time you accumulate, and you don't have to make a big investment until you can have a minimum to be redeemed. Yes, it's more practical. Yes, it's immediate. Saludando Plan, a friendly plan that supports you and says hi.
Only you know what God can do. When you're laying down in that hospital room, don't think you have nowhere to turn. Steps right